Good afternoon and welcome to the NCCN Policy Summit webinar, Innovations in Cancer Care Throughout the Ages. My name is Nancy Lewis and I serve as the Chief Scientific Officer of the National Comprehensive Cancer Network. And on behalf of NCCN, I'd like to thank our virtual audience for joining and participating in today's summit. We encourage you to engage with our speakers by submitting questions through the Q&A tab. The topics are far too complex to fully address in just one webinar, so we hope that the oncology community will continue these conversations by carrying them online and in person to those who are unable to join us today. So the focus for today's summit is how key innovations in cancer therapies and treatment modalities have led to the modern oncology care paradigm, along with the importance of maintaining an innovative ecosystem to benefit future generations of people impacted by cancer. And according to the American Cancer Society, between 1991 and 2023, the overall cancer death rate has dropped by 34%, resulting in an estimated 4.8 million fewer cancer deaths. This improved survival rate isn't just confined to early stage cancers. Late-stage cancer 5-year survival rates doubled from 17% in the mid-1990s to 35% for those diagnosed from 2015 to 2021. And this is the result of decades of cancer research, providing healthcare professionals with the tools to treat cancer more effectively. However, significant federal changes coupled with long-standing systemic hurdles have created new challenges for American leadership in this space. Today's topics will explore past successes realized through a collaborative, supportive research environment, areas of promise for future innovations in cancer care, and how the current clinical research ecosystem is structured. Our speakers today will explore the importance of clinical trials in the development of novel therapies, challenges and opportunities across the practice and policy landscape, and best practices and innovative partnerships, and opportunities to strengthen the cancer treatment innovative pipeline. Can you advance the next slide, please? We're very grateful to the many supporters of today's program. We want to thank our sponsors for their generous support, because without this event would not be possible. On the next slide, we have today's agenda shown. We're going to start with some congressional remarks by Diana DeGette, who is a member of the U.S. House of Representatives, and then that will be followed by Dr. Christopher Lieu's keynote address and an expert panel led by Dr. Clifford Goodman. And today we will welcome all of today's speakers and thank them for sharing their time and expertise. On the next slide, I do want to make a point to note that while we're very happy that our speakers can generously share their time and insights today, the perspectives and opinions are those of the presenters. On the next slide, we have our moderator for today's panel, and this is Dr. Clifford Goodman. He's an expert consultant in healthcare policy and technology, and he has over 30 years of experience working with the government, industry, and nonprofit organizations, not only in the U.S., but also abroad, in areas such as health technology assessment, comparative effectiveness research, clinical practice guidelines, and health economics. And our NCCN audiences are familiar with his moderating abilities, and we're thrilled to have him join us today for today's discussion. So I'd like us to get started. On the next slide, I'd like to introduce Representative Diana DeGette. She's from Colorado's 1st District, and she's provided some recorded remarks for the event. She is a member of the U.S. House of Representatives and a 4th-generation Coloradian. She's serving the people of Colorado's 1st Congressional District. She's recognized as a leading voice in the nation's healthcare debate and as the top Democrat on the House Energy and Commerce Health Subcommittee. She's played a leading role in overseeing the nation's healthcare agencies and the nation's overall response to the COVID-19 pandemic. Representative DeGette believes that Congress has a responsibility to make healthcare more accessible and affordable for all Americans. And among her congressional colleagues, she's seen as a leading expert on cutting-edge scientific research, including the use of human embryonic stem cells. Representative DeGette has been instrumental in expanding the state's Children's Health Insurance Program, which provides health insurance to low-income children, and she also played a key role in drafting the Affordable Care Act, which President Obama signed into law in 2010. Despite her many accomplishments, the one piece of legislation that Representative DeGette is best known for championing is the 21st Century Cures Act, which has modernized the nation's medical research system. The bill, which is simply known as the Cures Act, has been widely hailed as one of the most important pieces of legislation that Congress has passed in recent years. From cancer research to precision medicine, it's enabled more labs to make more breakthrough discoveries, and hopefully these will soon lead to new cures and treatments for patients around the world. And we deeply thank Representative DeGette for her leadership in the healthcare space and for providing us with her remarks for today's program.
Hi, I'm Congresswoman Diana DeGette, representing Colorado's 1st District. Though I couldn't attend today's policy summit, I'm thankful to the National Comprehensive Cancer Network for inviting me to speak on such an important topic. In the House of Representatives, I have the distinct honor of serving as the ranking member of the Energy and Commerce's Health Subcommittee, which has jurisdiction over public health agencies like NIH and FDA, as well as Medicare and Medicaid. In this role and throughout my time in Congress, I've been focused on making sure that health care and Americans' access to it stays at the forefront of the conversation. One of my proudest achievements in Congress has been passing the 21st Century Cures Act. The idea behind cures was simple but powerful: to accelerate the development of life-saving cures from diabetes to dementia. As we learn what treatments work for patients, that data feeds back into the research, setting up new breakthroughs. For decades, that cycle made America the biomedical innovation capital of the world. The 21st Century Cures Act was about making that cycle work even better. As you know, we've made some incredible progress in the fight against cancer over the last few decades. The numbers are even telling the story. Through 2023, cancer death rates kept falling, saving nearly 5 million lives since 1991. Early detection is becoming more common, and treatments are working better. That's what progress looks like. But I would be remiss if I didn't also acknowledge the severe backslide our nation's public health workforce has seen. Given indiscriminate firings at FDA and NIH, political interference in public health agencies' missions, and divestment in basic research, our public health institutions have been severely damaged, and we have more obstacles popping up every day. Congress must right these wrongs and build up our public health system, from biomedical research to regulation to care delivery, and fix what is broken and improve on our successes. That future is ahead of us now, as the work to build on the historic success of the 21st Century Cures Act continues. Ultimately, I look forward to passing an update to Cures, which will enable the rapid deployment of innovative technology to improve health outcomes. It will also help us build infrastructure to seamlessly gather evidence and deploy it into practice, and foster innovations that improve patient care, all of which will directly benefit cancer treatment and research. To achieve this, our top priority must be ensuring our public health agencies have the resources and the expertise they need to promote and safeguard the health of the American people. Health research and innovation have always been bipartisan priorities. It's critically important that they continue as such. We must also make sure that scientific decision-making is not substituted for politics and ideology. That's why I introduced the Follow the Science Act, which limits the number and influence of political appointees at NIH. Furthermore, we need NIH Institute and center directors who are universally respected and hired on merit, and not because of who they know in the White House. Diseases like cancer don't care about which side of the aisle its victims sit on, and that's why we shouldn't let partisanship or political games get in the way of real life-saving progress. Cancer is among the leading causes of death in the world, which means statistically, most everybody listening to this right now either lost someone or knows someone who lost a loved one to cancer. It's with that understanding that we should strive together as a nation to continue support for research efforts that could lead to future cures and new technologies for cancer care in the United States. I want to thank the National Comprehensive Cancer Network for all the work that they do in advocating for patients and for allowing me the opportunity to speak with you all. Thank you for carrying on the fight to lead with science and evidence to advance cancer care and to safeguard public health.
Well, we very much appreciate Congresswoman Diana DeGette's comments, and she didn't pull any punches. I think she was pretty clear about the original intent of the 21st Century Cures Act. She noted that it's due for an update, and she's working on that. Furthermore, she used the term damage that she's concerned about. She's worried about our public health agencies and their viability and trustworthiness. She distinguished between and called into our attention to the distinction between scientific decision-making and political influence. So she was pretty clear about the need to pursue this. I think that she also expressed some concern about what we'll get into later, which is this sort of biomedical research and development pipeline that has been developed over the last several decades. This is something we're going to address later, but we really appreciate Congresswoman DeGette's comments. And we'll let her know that she set this up very well for the rest of our webinar here. With that, I want to introduce Dr. Christopher Lieu. Chris is the co-director of Gastrointestinal Medical Oncology Program at the University of Colorado Cancer Center. I can just tell you that his presentation is not going to be what you might expect in a typical sort of research orientation. He's going to get into some history and kind of give you the big picture about the evolution of the field and where it needs to go. This won't be your average presentation, let me just put it that way. And Chris, by the way, at the top, could you just also mention your role, or I should say roles, in the NCCN guidelines program, and I'll hand it to you now.
Absolutely. Thank you so much, Cliff. And again, echo your thoughts and sentiments about the Congresswoman's remarks. And I think that those were really just outstanding. Thank you for the introduction. My name is Chris Lieu. I'm a GI medical oncologist here at the University of Colorado Cancer Center. And I also serve on the board of directors for NCCN and also serve on the NET guideline panel for NCCN as well. So as Cliff mentioned, this is going to be a bit of a different talk altogether compared to some of the scientific talks that we typically give. And really, it's a little bit of a history lesson. And I hope that you come away from this lecture really kind of understanding maybe where we've been, the humble beginnings of cancer care and cancer therapy, and why I think now is without question the most exciting time that I've ever seen, right, in the field of cancer medicine and cancer therapy, cancer treatment. And I want to talk about, how we're going to get better. Where is the field going? So, I want to start off with a case that I think really brings all that we work on home. And unfortunately, this is a very young patient that I recently actually saw in follow-up in clinic just last week. But she's a 31-year-old female with no past medical history, completely healthy, and presents with a 6-month history of just seeing some blood in the stool, thought it was hemorrhoids. But on exam, there's a mass, and so colonoscopy was obtained, and showing this mass that you see in the bottom left-hand corner, and that's a mass in the rectum, and so this is rectal cancer. And when we look at the pathology or the biopsy specimen underneath the microscope, what we see is that this is a poorly differentiated adenocarcinoma, and it has a biomarker called microsatellite instability high, and we're going to talk about why that's important and how that impacted her treatment. We got some staging studies, and so a CT scan showed no evidence of metastatic disease, so that's great news. But we got an MRI of the pelvis, which showed, well, what I'm showing you in the red circles is that this is a rectal mass, and then you see a lymph node there that's enlarged as well. So this is what we would call stage 3 colorectal cancer. And, it's kind of the traditional way we would treat this would be with a combination of chemotherapy and radiation therapy. But the problem is that whenever you give radiation to the pelvis, you have the chance of actually sterilizing the ovaries and actually flipping somebody into menopause at a very early age. And she's obviously very desperate to avoid anything that might cause that. And so we're going to go through a history lesson, right? So if you take this patient that, again, I just saw him follow up last week, how would this patient be treated? As far back as 2000 BC, 100 BC, 1970, and 2026, and we'll tell you how this patient did. But we're going to kind of go through the history of that as well. This is just a public service announcement. These are the kind of curves that we want to see when it comes to the incidence and mortality of any cancer. And this is in our older individuals. And what you see here is that the incidence and mortality from colorectal cancer in our older individuals has really been decreasing at a really astounding rate. And this really proves how powerful prevention can be. And we all know that everybody needs to get a colonoscopy at the age of 45. But unfortunately, we've seen this trend over the last 2 to 3 decades of young patients being diagnosed with colorectal cancer, again, at an incredibly early age, seeing this in both males and females. And, I presented this slide back in November, and I said, colorectal cancer is going to be the #1 cause of cancer-related death in our young patients by 2030. And unfortunately, the pace has increased so rapidly that colorectal cancer is actually now the leading cause of cancer-related death in patients younger than 50. So this is an incredibly huge public health problem. And what you're seeing here with these red lines is the overall death rate in our younger population from colorectal cancer. This is something that we're not only just seeing in the United States, but we're actually seeing it relatively globally. And so you're kind of seeing an entire map of these increases in our early onset patients with colorectal cancer. And so not just a United States problem. And so, one of your take-home messages here that I hope you get away with, from this talk with is that the incidence of colorectal cancer in our young patients, is increasing globally. And so to the point about research and where the field is going, I can't tell you how critical research is in this field so that not only can we treat our young patients better, but obviously have an idea of how we can prevent this in our entire population. All right, so I'm going to start with who first described cancer, because I do want to talk about how we would treat my 31-year-old patient, all the way back in 2000 BC. I actually give this kind of a lecture to one of the local high schools here. And I said, when was the first ever description of cancer? And they all looked at me and they came up with 1986. And after, I kind of recovered from that and stood back up, I said, okay, you guys are going to have to go way further back in history to talk about, when cancer was first described. And then they said 1975. And I, at that point, gave up and said, okay, well, we're going to be here forever. We keep having you guess. So the first description of cancer was actually in 2600 BC. There's this kind of manuscript from Egypt. They call this the Egyptian Edwin Smith papyrus. Edwin Smith clearly was not an Egyptian. That would be a crazy name in 2000 BC, but he was the one who actually purchased this. This is a relatively scientific manuscript for the time. It was attributed to the Egyptian physician Imhotep, and it described essentially breast cancer, a bulging mass on the breast, large, spreading, and hard. And there's a total of 8 cases described. And he said that they were treated with a cauterization tool known as the fire drill, which sounds really, really terrible. And it was interesting. He kind of wrote that, are there any effective therapies? And he said, well, there are no effective therapies. And so, when you think about how this patient would be treated in 2000 BC, it's either with the fire drill or it would be essentially with magic. And that's essentially, how all of these diseases were treated back in, 2000 BC. So, in the interest of time, we're going to jump ahead about 2,000 years and talk about another early description of cancer. And, we talk about cancer as being, like a carcinoma. This actually comes from the Greek word crab. And so Hippocrates describes several kinds of cancer. And what he was actually describing was tumor angiogenesis, this idea that the cancer actually had to grow its own blood vessels to continue to grow in size. And he noticed that the appearance of the cut surface of a solid tumor with the veins stretched on all sides as the animal, the crab, has its feet. And so that's where we get the name carcinoma or carcinos. It actually comes from the Greek word crab. So the question is, well, then what causes cancer, right? We have some descriptions of cancer from Egypt. We have a Greek kind of description of cancer. Well, Hippocrates had the humoral theory. And so he said that there were 4 humors that could affect health: blood, phlegm, yellow, and black bile. And so when you see this kind of this graphic on your right, if this is essentially how you assume that disease comes about, well, then that will impact how you're going to treat cancer as well. So Hippocrates suggested that well, cancer may be caused by an imbalance of black bile. So the way you would treat cancer would be to get black bile out. And so hopefully you guys have already eaten your lunch. I've shown you a picture here of a leech. But in 100 BC, this is how they treated cancer. They would bleed you. They would throw leeches on you. And I just kind of basically say, well, this is overall badness, right? This is not what we would hope to get out of modern medicine. But this was essentially how cancer was treated, again, around the time of 100 BC. Of course, when it came to cancer, we're going to jump ahead again about another, 1 or 2 millennia. And there were a lot of hypotheses here. There are 2 doctors, Lusitani and Tolt, that were doctors in Holland, and they concluded that cancer was contagious. And what they were noticing was breast cancer that was developing in members of the same household. We now know that they were probably describing a genetic predisposition to develop breast cancer. And that's exactly what they were seeing in the same household. But they, instead of saying it's genetics, they said it was infectious disease. And of course, this led to cancer hospitals being put into incredibly rural areas because they were scared that, well, people would actually catch cancer. The Scottish surgeon John Hunter, who lived from 1728 to 1793, suggested that some cancers might be cured by surgery. He was, of course, correct. You might imagine that if surgical anesthesia wasn't really successfully utilized until the 1800s, any surgery that was done in the 1700s would have probably caused a lot of damage and probably would hurt a decent amount. But then moving into the 1800s, Virchow, who's kind of known as the father of modern pathology, he hypothesized that cancer or growth could occur in either 2 ways, by either increasing cell numbers or increasing cell size. And so what he was actually describing was hyperplasia and hypertrophy. And he deduced that cancer was a disease of pathological hyperplasia, and he was 100% correct. And so, we've talked a lot from 2600 BC all the way to almost 1900 of descriptions of cancer. You've heard a little bit about surgery before the advent of anesthesia, right? So these are all very, very terrible things. Well, what about the idea of giving a medicine to treat cancer? And this history is actually much more recent than you might imagine. And so we want to go into, well, what is the history of the drugs that we use to treat cancer? Where did these cancer drugs come from? This term, chemotherapy, was actually defined as the use of chemicals to treat disease. But Paul Ehrlich, the German chemist who coined this term, was actually looking for something to treat syphilis, not even cancer. But that's going to bring us to the advent of chemotherapy. And what I'm showing you here is a picture of World War II. And so this was a German bombing at Bari, Italy. Bari, Italy had a harbor where a lot of Allied ships were essentially stationed at, thought to be out of the range of German bombers, but this was proven to be very, very incorrect, as there was a significant bombing that happened in Bari, Italy, that really hurt the Allied forces. One of the ships that was bombed was this ship, the U.S. Liberty, SS John Harvey. And what this ship contained, or the payload that this ship contained, were 2,000 M47A1 mustard gas bombs. Now, this was a completely top secret payload within the ship, because chemical warfare was not allowed in World War II. So this ship and its supply of mustard gas bombs should have never been there. And so very, very few people knew, even in the port, that this ship was actually carrying chemical weapons at the time. The problem is, when you bomb this ship, you actually aerosolize the mustard gas. And so fishermen and residents began to complain of smelling garlic and horseradishes in the breeze. And what happened was there was an initial casualty from the initial bombing, but then thousands of people started dying the weeks following the bombing. So they survived the bombing, but then they started to pass away in Bari, Italy. So when they did autopsies of the civilians and the soldiers that were there, they revealed that the white blood cells had completely vanished in the men and the women who initially survived the bombing. And so there was a chemical warfare service that was created to study war gases. And there are 2 scientists, Goodman and Gilman, that were contracted to study nitrogen mustard. And so what they did was one of the first preclinical trials. Now, I tried to show you the cutest bunny I could find in your top right-hand corner. But essentially what they did was inject nitrogen mustard intravenously into rabbits and mice. And what they noticed was that the white blood cells in the bone marrow had actually disappeared, but they didn't get any of the toxic vesicant actions that we have seen in movies and in historical documents. And so they were able to wipe out the bone marrow within these rabbits and mice. And so in 1942, they persuaded a thoracic surgeon, Gustav Lindskog, to treat a 48-year-old male with lymphoma with 10 doses of IV mustard, and they caused a remission. Can you imagine in 1942 what informed consent looked like? What this clinical trial looked like? This was kind of like one of the first clinical trials. And this patient with lymphoma just getting this chemical warfare weapon just directly injected into his vein. But they did it. They caused a remission. What's interesting is that this happened in 1942. They didn't even publish their findings until 1946 because all this information was embargoed because, again, what happened with the John Harvey ship. Around the same time, there was a pediatric pathologist named Sidney Farber. And he decided that he wanted to move away from the microscope and then start treating kids. And so he actually made a career transition from pediatric pathologist into pediatric, oncologist, even though the field didn't even exist then. But in the 1940s, he saw, people were being treated with penicillin to treat infectious disease. Well, he thought maybe a drug could be developed to treat kids with leukemia. And so Sidney Farber had also gotten some information from Lucy Wills, who's one of the heroes, right, in medicine and science. And Lucy Wills is famous for observing that folic acid could restore red blood cells in nutrient-deprived patients. And so Lucy Wills had figured out, if patients have folate deficiency, they can't make enough red blood cells. And so Sidney Farber said, if folic acid can help anemia, why can't folic acid help kids with leukemia? And what the problem with injecting folic acid into kids with leukemia is that it's almost like pouring gasoline on a fire, just giving the cancer everything that it needs to proliferate. And so Sidney Farber actually found a way to make childhood cancer actually worse. And so when this happened, he actually got kind of shoved into the basement of the hospital, and they're just kind of like, you actually made the worst disease ever even worse. So maybe just kind of hide, right? And don't be in a recognizable part of the hospital. But he didn't give up. And it's actually a really important lesson. It's just saying, if this actually made cancer worse, maybe something that works in the exact opposite way will make cancer better. So he had tried an antifolate and there was no impact. And then he got a more powerful version of an antifolate called aminopterin. And he found that the white blood cells began to drop to nearly 1/6 of its peak value. And these kids couldn't walk. They had a tremendous amount of fatigue, but their spleen and their livers were huge. And so they were not even able to walk around. And so the patient that he treated began walking again, and the patient's spleen and liver returned to the normal size. And so he actually published these findings in 1948. 10 out of 16 patients had actually responded to aminopterin. And you think about how humble these beginnings are of this person in the hospital basement giving an antifolate, hoping to treat kids with leukemia. And the success here were that 5 kids remained alive 4 to 6 months after diagnosis. And of course, this was one of the biggest advances ever, right, in the history of cancer medicine. And I just showed a slide to tell you, you can go from the basement of the hospital and still get your name on the building. So this is a picture of Dana-Farber Cancer Institute. And what I'm showing you on the right side is the survival rates of acute lymphocytic leukemia in kids. And what you're seeing here, going from 5 kids who lived for 4 months, and that being a tremendous improvement, to now kind of seeing these cure rates of over 90%, which is really astounding. And this is largely with chemotherapy only. So the field has come an incredibly long way, and you can see that benefit whenever you look at a graph like that on the right. All right, so I don't want to, we're talking a lot about drugs, but I don't want to discount the fact that surgery and radiation have made incredible strides. William Halsted at Johns Hopkins pioneered a radical mastectomy in the 1890s. There was a medical student named Emile Grube, who was a 21-year-old medical student who decided to try giving patients with breast cancer radiation using an improvised X-ray tube, which sounds incredibly dangerous, but was unbelievably innovative and actually started the field of radiation oncology, but of course had significant radiation toxicity himself because he's just like shooting these X-rays in an improvised X-ray tube. And again, you can imagine like how wild these beginnings were, even for a field like radiation oncology. All right, so going back to my 31-year-old patient with rectal cancer in 1970, I'll say even in 1980 and 1990, this patient would largely probably get surgery, maybe some radiation, and there was just one chemotherapeutic drug, 5-fluorouracil, that could be used to treat her cancer. And so we've kind of gone from magic and the fire drill to bloodletting and leeches, and then finally in 1970, right, almost 4 millennia later, we're finally getting to surgery and a drug that we know as chemotherapy. All right, so it's fun bringing you through 4,000 years of history, but the question is, well, where are we now? And I want to talk about where we are in terms of the advances in targeted and immunotherapy. When you look at the field of colorectal cancer oncology, again, from 1950 to 2000, there was essentially one drug to treat anybody with colorectal cancer, and that's number one here, 5-fluorouracil, a drug that we still use in practice today a lot, unfortunately, but still an effective drug. But you can see here that there are several chemotherapies that are approved for metastatic colorectal cancer. But then as you look at the bottom half of this slide, there are a lot of targeted therapies and immunotherapies that have been developed for the treatment of colorectal cancer. I want to speak a little bit to how we use some of these targeted drugs and immunotherapy drugs, and even how that's going to, how that did impact my patient. So, the problem in cancer medicine is this slide, and that is a one-size-fits-all strategy. You have, no matter, what your environmental exposures were, your genetics, the tumor's genetics, and what the tumor looks like, we're going to treat you all the same. We're going to call colorectal cancer a disease that's probably 100 diseases, and we're going to say it's just one disease. And so if we do a one-size-fits-all treatment, we shouldn't be surprised if one patient has a phenomenal response to therapy, but then 4 patients have no response at all, but they receive side effects from therapy. And so what we want to get is to this point where we can learn more about our cancer, about somebody's cancer, and then offer a treatment that's personalized to that patient. And the field of this really started to take off in the 2000s. And I remember being at MD Anderson in fellowship and seeing this drug come through in a phase 1 clinical trial. We're going to talk a lot about clinical trials in our panel discussion, but I'm going to tell you why this is so important, because for many, many decades, there really weren't any effective therapies for melanoma. We used some chemotherapies that were toxic but not very effective. But we know that there's a certain percentage of skin cancers that have a mutation in a gene called BRAF or BRAF. And at the time, in a phase 1 clinical trial, I saw this happen in clinic where a drug was designed to target BRAF. And so, hey, if a patient's got a BRAF mutation and we have a drug that can target BRAF, what does that look like? And so this is a patient that has a tremendous amount of melanoma tumors all over the body. You see that on the PET scan on the left. And you can see what that PET scan looks like 6 weeks after initiating the drug. What does that look like when you see the patient in person? This is a picture of the patient's chest. You see a lot of in-transit lesions or tumors from melanoma. And after 6 weeks of a BRAF inhibitor therapy, you see, this is, believe it or not, the same patient. And this is what we were seeing in a phase 1 clinical trial. And when we talk about the importance of a phase 1 clinical trial or any clinical trial, this is the kind of difference that we want to see. So the question is, well, have we cured melanoma, right, with this one drug? And we know that after several months, there's actually a relapse. That cancer is very, very smart and finds a way around some of these targeted therapies. And so we shouldn't be surprised, even when we get these incredible responses, that when you have a signaling pathway that is this complex, right, that just hitting one of these targets may not be good enough. And so as we learn more about cancer's behavior, cancer's biology, we can start to attack this pathway in a more effective way. And I'm going to show you that here in just a little bit. Can we personalize our therapy with cancer? I'm going to show you what the snapshot was of molecularly directed therapy for metastatic colorectal cancer was about 10 to 15 years ago. So this is what our kind of personalized therapy pie chart looked like for metastatic colorectal cancer in 2011. This was around the time that I was just starting my career. So we just had one gene that we were testing for, and everything else was kind of unknown. And so I would say now in 2026, our pie chart looks at least a bit better. And so when you look at the pie chart on the left, you can start to see some actionable mutations. And you can imagine that even though these pie slivers are very, very small, if you continue to chip away at this pie 2%, 3%, 4% at a time, you're going to impact more and more of a population. And that's what they have done in lung cancer. You can see with lung cancer how many actionable targets there are. And so colorectal cancer, never thought I would be jealous of thoracic oncology. Here I am. So colorectal cancer, we're trying to get to become more like lung cancer. All right. Can we do better with targeted therapies? This is what's made all the news. KRAS has historically been an undruggable target. We said this cannot be drugged effectively. And the reason why is because KRAS, this target, is kind of like a greasy ball. It's hard to attach a puzzle piece to it. Everything just kind of slides right off. And so I will tell you that the development of this drug took over 10 years. But this idea of attaching to something that naturally attaches to KRAS, it kind of forms this tri-complex of the drug, kind of like an intermediary, and then the gene KRAS, and it forms an inhibitory complex. And this was the drug that led to a near doubling of overall survival in one of the hardest cancers to treat, pancreatic cancer. And this was just presented at the ASCO annual meeting a couple of weeks ago. And this is what led to a standing ovation. And again, is it perfect? Is it a cure for pancreas cancer? It is not. But these are the type of advances that are so meaningful to our patients, because chemotherapy works so poorly in this disease that anything that can extend overall survival like this in a horrible disease like pancreas cancer really is just a true amazing advance. And what's even more important is that the quality of life of these patients is better compared to those patients getting chemotherapy. And I think we'll talk about this more in our panel session. I'm going to wrap up the targeted therapy session saying that, well, within oncology, you can use a target to attach a bomb to it. And so there's a new field emerging within oncology called radioligand therapy, where you can take a target, attach something to the target, in this case, a neuroendocrine tumor cell, and actually deliver a radioactive payload. And I actually have a video to show you how this works. And so the radioisotope here is lutetium-177. It releases a gamma ray and a beta particle. Those are always two fun things to say, but these are, of course, destructive potential. And essentially, all this is a molecule that attaches itself to a neuroendocrine tumor cell. And so it's as simple as, I say it's simple, but you're injecting it into the vein, obviously under careful precautions because it is a radioactive substance. But once it circulates into the bloodstream, it's kind of like Velcro. If it doesn't attach to anything, you just literally pee it out and your kidneys filter it out. But if it attaches itself to the tumor, it can actually deliver a dose of radiation inside the cell. So you're going to see this molecule attached to the receptor. It gets incorporated into the cell, and inside the cell, you have detonation. Now, of course, I always joke with my trainees whenever I show them this video that this is clearly what happens, right? The tumor cells just explode. This is obviously a cartoon, but it is a really nice principle of like, hey, if you can find the target, you can attach something almost like opening the door, throwing a grenade in, and shutting the door. And that's what we see. And we've seen significant survival benefit in neuroendocrine tumors. And that's the guideline panel that I currently serve on. All right, I'm going to wrap up the treatment section with this. And that is, one of the hallmarks of cancer is cancer's ability to evade the immune system. And so one of the big advances over the last decade has been the advent of these drugs that essentially tell T cells to turn on. There are these receptors on the T cell and on the tumor that act as a stop signal for the T cell to not kill the tumor cell. So these drugs are essentially antibodies that block this interaction. And you go from a stop sign to a go signal. And what's important is that in our patient that we had talked about, my 31-year-old patient with rectal cancer, her biomarker of something called microsatellite instability creates a very, very kind of inflammatory environment because the tumor is really, really mutated. And what's interesting is that these brown dots that you see on your right are just T cells. They're just sitting in the tumor. They're just waiting to be turned on. And so when you think about my patient with this rectal mass, well, could we offer her immunotherapy instead of chemotherapy or radiation therapy? And that is actually what we ended up doing. We started this patient on chemotherapy It did not work at all. There was actually a new liver lesion, so we were worried that there was actually stage 4 cancer. We gave this patient a couple of months of immunotherapy, a drug called pembrolizumab, and the patient had no side effects to this. And what I'm showing you here is a complete response on the MRI, what this looks like under a scope. You see the tumor on the bottom left-hand corner of this picture right here. After several months of pembrolizumab, you see the complete disappearance of this tumor, and there's just a scar. So this was what we call a complete clinical response, which is always really exciting. And this patient actually forego surgery. So she was essentially with a drug cured of her cancer, and she has no evidence of disease. And I've been seeing her for about 3 or 4 years, and she is doing great without evidence of cancer. And obviously, one of the most important things is that we were able to preserve not only her quality of life, but her fertility as well. We're entering into a field where the clinical trials and the drugs are becoming incredibly more complex. We are seeing the advent of something called CAR T therapy, where we are actually removing T cells from the patient's body, reprogramming them against cancer, and then re-injecting T cells back into the body. This has made incredible strides in blood cancer. What I'm going to show you is actually a patient with colorectal cancer. And what you see here on the CT scan in the middle of the picture is this tumor that's actually trying to protrude out of the patient's abdomen. So this patient, she could actually feel the tumor pressing up against her skin. And this is not always the case, but sometimes these immunotherapies, and this patient was on a CAR T study, just have these dramatic differences in their cancer. And we ended up having to biopsy this kind of remaining thing that you see in the center of your screen, and it was just scar tissue. It was just completely free of cancer, which is pretty remarkable. And then you're going to see a lot more data on vaccines, both preventative and therapeutic. I think that there'll be interesting data coming out in pancreas cancer on vaccines as well. And so I think that this is another emerging field for immunotherapy. I'm going to wrap up with some things that I think are just extraordinarily important. The best way to treat a cancer is just to prevent it. And so not all the advances are purely in treatment. We certainly want better ways to prevent cancer. I will tell you that we already have a lot of the tools that we need to prevent a lot of the cancers in our country. And so what you're looking at here are colorectal cancer screening rates across the nation. And this is data a little bit older from 2020, but find your state, right, on this map. Here in Colorado, we're at 63%. Can you imagine how much less colorectal cancer we would see if that number were 80% or higher? And we know that one of the biggest things that will predict the use of a cancer screening test is really insurance status. And so you can see that if you're insured, your rate of getting a screening test is 71% versus only 50% if you're uninsured. There is an evolving field of looking for cancer using a blood test. We know that cancer can dump a whole lot of things into our bloodstream, but one of them are these fragments of their tumor DNA, which when you draw blood, you can actually detect the presence of cancer. There are tests being developed that try to identify a cancer before you can see it on a scan. And there's been a big proliferation of these tests. I'm showing you data of one of these multi-cancer early detection tests. You can see that it does a great job with some cancers at finding them. You can see that it doesn't do a good job of other cancers of finding them. This is going to be a field that evolves very, very rapidly. And I put this disclaimer up because this is a field that has a lot of controversy as well, because I think the technology has actually outpaced our ability to know, how best to utilize it. And then I'm going to wrap up with this, and that is, one of the best ways we can cure cancer is not only through multidisciplinary care, but to ensure guideline adherence. To talk about early onset colorectal cancer, this is a really, really nice study from the MD Anderson group showing that if you don't follow guidelines, you're not only probably not using resources in an efficient manner, but you may actually be hurting patients. And what you're looking at here are survival rates when patients receive within guideline-based care versus outside NCCN guideline-based care. So it's just some final thoughts, and then I'm going to lead us. So number one, happy to take any questions. So please put them in the Q&A. if you have any questions. But I'm going to wrap up with just some final thoughts, and then we're going to dive into the panel discussion, which I think we have had just an incredible panel here to talk about the future of cancer and clinical trials. But this is without question, I think, the most exciting time that I've ever seen in the history of cancer. And you think about like 4,000 years of just like not doing anything super effective. And then the advances that we have seen, even in the last 10 to 15 years, has really just been wild. And the pace is truly extraordinary. But I will tell you that in an evolving field, not only do we need to educate our patients, but the resources needed for this are going to be increasingly critical. And of course, the best way to treat a cancer is to prevent it. We want age-appropriate screening. And I will tell you that this field of cell-free DNA and ctDNA will continue to improve. We're going to talk a lot about research funding, right? When you think about these stories, what led to these great outcomes that I was able to show you? And it really starts at the bench and then goes all the way to the bedside. So that research funding is increasingly becoming critical. And of course, how do we get these drugs to patients? And we know that the FDA has multiple avenues for this, including an accelerated approval pathway, which I think has really helped get drugs to patients faster. But we're going to talk about the time that it takes to develop these drugs. How are we going to pay for this? If I was going to give 6 months of 5-fluorouracil, which was, by the way, the overall survival in about 1995, well, that cost $6. Well, my patient is now cured, which is amazing, but that drug costs roughly $13,000 per vial. And so I think that it's going to be important for us to understand what the economics are of these drugs and to ensure that we have equitable access to our patients. And so that's the thing. Whether no matter race, ethnicity, urban or rural, we just want to make sure that we ensure access to cutting edge care. One of the most important things that we're going to talk about in the panel is, well, what about clinical trials? I showed you what the results of a lot of clinical trials, but how that actually impacted individual patients. And so can we increase access to clinical trials for all populations and ensure that, well, we're just giving everybody the best care possible? Okay, and with that, Cliff, I'm going to turn it back over to you, and happy to take any questions that come up.
Well, thank you very much, Dr. Lieu. I can assure you that I'm going to be studying for the quiz. That was quite, I should call you Professor Lieu from now on as well. You took us through by my arithmetic, a 4,600-year history of cancer care, all the way from magic through fire drills, bloodletting, chemotherapy, surgery, radiation, molecular-directed testing, the KRAS greasy ball, radionuclide therapy, immune checkpoint therapy for MSI high cancers, CAR T, liquid biopsies, and other MSEDs. Not bad. We get it. That's a wonderful sort of series there. We did have a couple of questions come in, and we might have a chance to answer these. We'll take a couple of them during the panel, actually. But with regard to sort of the patient role in all this, are you looking at early access to genetic testing for some of these cancers as a way to kind of get an early start or to catch the cancer early? Where do you see the genetic testing field insofar as patient readiness to kind of utilize those?
Yeah, thanks, Cliff. And, I think that genetic testing can sometimes mean two things. Number one, the kind of what we traditionally think about hereditary cancers testing or genetic testing are the genes that we inherit from our parents. And I think that access to genetic testing is extraordinarily important because I think it's important sometimes even for treatment. But it's important for somebody to understand the risk of future cancers, but it has tremendous impacts on their family and what their screening might look like. And so particularly in my younger patients, and so the 31-year-old patient that I used as an example, that was a great example of that patient needs genetic testing, not only for her own risk, because of course she's now free of cancer, but what about her kids, right? So I think that that's critically important. I think that there should be wide access to that just because, again, the best way to treat a cancer is to prevent it, find it early. The second thing is this idea of biomarker testing. And so you could tell that one of the reasons why we got immunotherapy approved for our patient and you saw that dramatic result was because we were testing for biomarkers. And, before, and, when I was completing my fellowship training, biomarker testing was kind of important, but it was kind of like the scientific thing. It's remarkable that in a decade, biomarker testing is critical. And this is something that has to be really, I think, physician-led, provider-led, but patient-led. And a patient really should be able to ask, has my tumor been tested for biomarkers? Because I showed you that pie chart for lung cancer, colorectal cancer. Every cancer has that now. And so, well, would you want a one-size-fits-all treatment, or do you want a specific therapy that's going to be better for you? And I think that that is a critical piece of information for all patients to understand.
Thank you, Chris. Another question before we go to the panel. What about the large language models, the ChatGPTs and so forth, and the Claudes and whatnot? Patients who are interested are increasingly, I hear, going to those sources. Are you confident that that will, at least in the short term or even longer term, result in better care or misguided care? What are the upsides of that, if not downsides?
Yeah, I think that there are certainly benefits and risks. I mean, I'll start with the benefits. I mean, having a higher level conversation with our patients about their cancer, having them ask me questions about biomarkers and things that they read, that, I mean, it takes time. And I think that in a stressed environment like healthcare, where you're just trying to get through, right, a lot of patients that need to be seen, it can be tough. But having said that, those are such critical questions to be asked. And I think that providers, for the most part, welcome those conversations, because it just means that we have a very, very informed population. I think that that's so critical. And I think that it means that our patients can access information that can sometimes be helpful for them without having to call somebody every single time, right? And in a way, may be able to fight some information, but then again, that goes to the risk of some of these large language models is, it depends on the prompt and the input. Are you prompting it correctly? Is the input correct? And then is the output correct? And so there's a little bit of danger when it comes to that of, are you fully comprehending the information that's being given to you? And is it applicable to you? Because that really depends on what you've put into the AI or the large language model to spit out back at you. And so a little bit of a benefit and a risk. I think for the most part, anytime you can provide good, correct and factual information, that's always a good thing. But there's a little bit of risk involved in that too.
Thank you, Dr. Lieu. We're going to spill a few of those questions back over into the panel, which I'm about to introduce. But I do want to point out, Dr. Lieu, without being explicit about it, set us up for this panel because looking at that 4,600-year history, I think the National Cancer Institute was founded in the 1930s, if I'm not mistaken. And so much of what Dr. Lieu described came from the basic biomedical R&D and other developments from the National Cancer Institute. And you brought us into the present, Chris, and some of the circumstances in the present are a little bit, I'll say, shaky, a little bit more uncertain, a little bit more risk going on there. We're going to kind of explore those. And we're also going to take a look at sort of patient viewpoint, the industry viewpoint as well, and sort of how industry works with NCI and other aspects of government to continue the innovation through more than that 4,600-year history. So with that, again, thanks so much, Chris, and glad you're sticking around for this panel as well. Our panel now is the changing face of cancer, past, present, and beyond. And I'll just give you some of the logistics on this. This panel is going to go from now until 3:25 p.m. Eastern time. So we've got a nice chunk of time here to cover this information. We will go to questions and answers no later than 2:55 or 3 p.m. Eastern. Some questions may come in earlier than that if they kind of flow into the current discussion. And I'll just let you know that what we're trying to do with this panel is addressing how key innovations in cancer care have led to modern oncology care paradigm, or paradigms, I should say, along with the importance of maintaining an innovative ecosystem. We're going to come back to that to benefit not only the folks today, but future generations. The subjects that we want to cover are as follows. First of all, the cancer innovation landscape. What does that kind of cancer innovation pipeline look like, and who kind of keeps it running? Clinical trials, as Chris Lieu mentioned, we're going to dive into clinical trials, including in oncology trials. What may be new and different about how trials are planned and run? What is the role or roles of artificial intelligence throughout the cancer innovation continuum? There's a bunch of places where AI may have a role. And then a pair of related topics. One is, well, what about American leadership in furthering cancer care innovation, as the Congresswoman DeGette pointed out. I think she was maybe a little concerned about that. And then related to that federal action, so to what extent have recent federal actions, the indirect cost caps, the tariffs, some funding cuts and some restorations, staffing cuts and some restorations, and even some geopolitical factors affected our ability to continue the cancer innovation pipeline. And of course, after that, we're going to get into a little bit about organizational support. So what are the roles of an ASCO, an NCCN, certain other agencies and organizations, patient advocacy groups in furthering cancer innovation, cancer care innovation? And then I'll have a surprise sort of closing question for our panelists. With that, and so to make sure that we can connect names with faces, I'm going to ask each of our 5 panelists to introduce themselves. You can find their bios in a bunch of other places. We're not going to do that, but I'm going to ask each person to say their name, their title, their affiliation, and briefly their connection to this topic, the changing face of cancer, and particularly with regard to innovation. And Dr. James Doroshow will start us off and set a good example. Dr. Doroshow.
Hi, my name is Jim Doroshow. I'm the director of the Division of Cancer Treatment and Diagnosis at the NCI. I'm a medical oncologist by trade. In respect to your last point, my job is to oversee basically the entire investment of the NCI in our diagnostic and treatment modalities.
Thank you, Dr. Doroshow. It's great to have you on this topic on this day. Next up, Randy Burkholder. Randy?
Thank you, Cliff. It's great to be here and great to be on the panel. Randy Burkholder, I'm a vice president of policy and research at the Pharmaceutical Research and Manufacturers of America. I cover a bunch of different issues, mostly day in and day out, related to Medicare policy, value assessment, and healthcare payment and delivery. And so a lot of that work ends up touching on how we end up valuing cancer medicines and innovative treatments and how we cover and pay for them, particularly in Medicare Part B and Medicare Part D. I'd also note I had the privilege of playing a small role in helping to found the Personalized Medicine Coalition, which is actually holding its 20th annual conference in November, I think, in Boston. So I hope to see you there.
Thank you, Randy. And just as it has been a very interesting year or so for Dr. Doroshow, it has been a very interesting year too for your industry, Randy. And
may we live in interesting times. Yes,
we do indeed. We do. Next up will be Chris Lieu. You've already met him. You know a lot about him. And like I said, we're studying for the big quiz coming up. Cassidy Moravec is next up. Cassidy?
Hi, everyone. Thank you so much for the invitation to be here. Happy to be on this panel. I'm Cassidy Moravec. I'm the Senior Director of Strategic Collaborations and Patient Advocacy with the Pancreatic Cancer Action Network. I've had the pleasure of working with PanCan for the last 16 years through patient services, through some of our clinical initiatives, through a clinical trial that actually PanCan sponsored, and now working with like-minded organizations, including ASCO and NCCN, on how we can really drive access for patients forward. One of those roles is I actually do serve as the patient advocate for the pancreatic adenocarcinoma NCCN guidelines panel, as well as the ampullary cancer guidelines panel. So happy to be here. And over the years, I've also served as a patient advocate on many other roles. So happy to bring that perspective.
Thank you so much, Cassidy. And I know you were listening intently to Chris Lieu's description of the KRAS ball and that breakthrough, how exciting. And as just an outside observer, I'd have to say that looking across the field of patient advocacy and oncology, well, patient advocacy throughout healthcare, PanCan has really set a high bar for not just pulling all the patients in, but really getting scientific about it and looking at evidence and so forth. You really get down to the scientific aspects as well as the policy intricacies. So glad to have you with us. And next is Dr. Catherine Rendell. Catherine?
Hi, everyone. Thank you so much for having me. Kate Rendell is fine. Kate. I am the director of the Penn Center for Cancer Care Innovation in addition to being an associate professor. I am an implementation scientist. I'm trained as an anthropologist and an epidemiologist. And so really what I do, both in my role as the director of the center, but in my own work, is really think about once we have these amazing innovations, they don't magically get into practice. So what is the science of implementation and dissemination that we can build on to make sure that once we have an innovation, that we can effectively, equitably, and efficiently implement into practice, not just in academic, but of course, community practice as well.
Thank you, Kate. And it really is important to have those additional professional and scientific perspectives. The anthropological angle is not inconsequential. We're learning every day about how to influence behavior and how people gain and access information and so forth. So great to have you on here. So let's start with the cancer innovation landscape. And I'm going to start with Jim Doroshow and just work through. We want sort of, if you wouldn't mind, what does the pathway or the pipeline look like? So if you could walk us through that pathway, even beginning with congressional allocations of research funding, the grant making and contractual process, and how this ultimately leads to innovations in cancer. And then, of course, after Jim Doroshow, we want Randy to weigh in on the complementary role of the biopharma industry. Do you have complementary, supplementary, duplicative roles? What do you do differently? And then Kate Rendell, how innovation therapies and treatment modalities can be accessibly implemented in the community. And Cassidy, of course, where does the role of patient advocacy in helping to kind of prompt and fuel the cancer innovation pipeline? So Jim Doroshow, can you get us started? I know you could spend a whole week on this, but can you give us a high-level picture of how the thing gets rolling?
Yeah, it really is a sausage. Okay. And most people don't understand all the various ingredients, but it really starts in pretty much end of January, beginning of February, when the president puts out his budget, his proposed budget. Not that that's what actually gets funded, but that's how it starts. And after that, and this actually happened only a couple weeks ago, there are usually a series of hearings by the Senate Health Committee and the House of Representatives in the Congress as well. And in those hearings, usually the NIH director, the NCI director, several of the directors of the big institutes go and try to justify their needs. They get lots of questions. It's actually kind of fun to watch if you ever get a chance to do that, because whatever we think our needs are, our job is to, at least my boss's job, who's the director of the NCI, is to support the recommendations of the administration, right? And so it's an interesting give and take as you watch that process, and that's all public in terms of what gets presented. And then through the course of usually the summer and early fall, the question is whether or not we actually get a budget. And does the House of Representatives actually put together a budget that includes HHS? That is one of the biggest budgets that have to be determined, because it includes Medicare, Medicaid, huge numbers, big dollars. And then the question is what gets voted out and when or if those appropriations actually get finalized and get the president's desk and get signed, right? Now, in the 22 years, I guess, I've been at NCI, there's been 1 year when we actually had a budget before October 1, before the beginning of the fiscal year. And in every other year, that budget goes on. Sometimes a year or two ago, we had a continuing resolution for an entire year, never had a budget. I just had the same amount of money as the year before. This is a big problem because, as everyone who has to go to the grocery market knows, expenses go up every year. And that's true for your groceries, but it's especially true for scientific, the price of hiring personnel for trials, the material you need to run a laboratory, the equipment, et cetera, et cetera. And so from any year to year, there are major implications for inflation in what those dollars will buy. If I were to make an average, I would say usually by February, the NCI will actually get its budget. We'll know what we have to spend. That takes not very long, usually a couple weeks, before it's delegated out to the various divisions. And then we basically set, depending on the amount of money that's available, we try to set priorities in terms of funding the grants that have come in and been scored, and trying to get those grants that, on a priority basis, get out the door. Sometimes that's very difficult if the dollars come in very late. That is to say, so if you have a budget and you only know what you've actually got to spend, and you find out in April, and you've been spending money since October 1st, that's a problem. And so we have to spend a lot of time trying to figure out how to allocate our resources so we never overspend, what we have. But basically, come usually March, April, May, we're in the process, getting a very, very busy time of trying to get grants funded, trying to get other resources funded, and get moving projects as they go out the door. It usually takes several months for this process, as some, I'm sure, in this audience and others listening know, grants get reviewed 3 times a year. So we are in almost a continuous process of getting in applications, looking at their scores, looking at the science, looking where the gaps are, and trying to figure out with the budget we have, how much can we fund, right? And that's true not only for the various grants that we have. We have lots of different kinds of grants, investigator-initiated grants. We also have monies that we disperse to various other kinds of networks that we support. And there's a lot of different process that has to go on. But usually there is something of a crunch late July in August. How are we going to spend all of our money that the Treasury actually gave us? Will we make sure that every dollar that we have goes out to investigators because they also have budgets, and institutions need to have a notification that the awards that we're going to fund are actually. It's a strange process because institutions get a piece of paper that basically say that you basically have a line of credit for a certain amount of money. And then and only after that piece of paper or the electronic file gets to the institutional administrative offices, can a laboratory investigator or a clinical trialist who has to pay for nurses or data managers, et cetera, can actually start to fund the money, to use the money. And unfortunately, when this process is delayed, those investigators have to rely on the good graces of their administration to provide interim funding until the finalization of the awards come in, and so that they can actually start paying their personnel.
So, Jim, without getting into the particulars of the last year or two, in general, do these machinations and delays and some of the uncertainties, do they have a practical effect on the cancer innovation pipeline itself, or does it right itself no matter what? It seems there's a lot of uncertainty in what you described, but does that really affect
No,
pace?
I can tell you that last year, the budget for my division, which is the largest subdivision of the NCI, okay, we on September 30th of 2025, we ended the year with a positive balance of 3 cents.
Which means to us lay people,
we spent every dollar and got every dollar that we were allocated by the taxpayers out the door, funded all the projects that we had hoped to fund.
Okay. And one more question before we kind of throw it over to Randy. Jim, can you just, at a very high level, this may not be easy to characterize briefly, but basically, what's NCI's role vis-a-vis preclinical stuff and getting into early clinical trials? What sort of sectors of the innovation pipeline are usually within the scope of NCI vis-a-vis when it goes over to industry, if I can be as basic as that?
Yeah, no, of course. What we do and what my division does, since we oversee the diagnostics and the therapeutic plans,
Right.
we actually have a pipeline. We call it the next program, right? And so this is a critical piece of the innovation pipeline in that we have resources. We don't give we have a series of contracts and grants for a network of about 50 organizations. Some of them are academic hospitals, some of them are CROs, some of them are chemistry sites, some of them are not-for-profit laboratories, so that if there is a project that a principal investigator has that is early on, we can take things as early as target discovery, as early as a high-throughput screen for a new target, and go all the way through screening of cell lines, animal screening, the production of drugs for actually clinical disposition, holding INDs, formulation, toxicology, and actually running early phase and all the way to late phase trials. So I can give you examples. Yeah, we can do the entire process, and we've taken many, many drugs from the beginning through into trials. The answer to your question, though, is that What this really does for academic investigators or for individuals who work at small not-for-profits is to give them access to resources that are really hard to come by. So it's expensive to run a high throughput screen. It's very expensive to do toxicology and formulation to get a compound ready for a clinical trial and to go through the regulatory aspects of that. And it really provides a link to get through the so-called valley of death. And
So that's what the federal support accomplishes.
Exactly. And one of the basically, if you think about it this way, and our focus really is on rare diseases and underserved populations, as well as where there are big chances that we need to take to make significant progress. Because I would say that there are two. If you look at this pipeline, there are two major outputs. One is the de-risking of early phase projects. So we get to the point where we have made a molecule, have actually put it into a small phase 1 trial, and then a small company can go out and much more easily get to venture capital because we have shown that whatever we've made either it hits its target or it's tolerable in a small number of patients. The flip side is for our late phase networks, we can do studies that really are not so much in pharma's interest. That is to say, multidisciplinary trials, radiation and chemotherapy, targeted studies in surgery, dose de-escalation trials that they're not money-making, but they could be very important for someone's quality of life. And I would say those are the kinds of areas that I think we make a difference. We're not in the business. I don't have the resources, nor are we in the business to compete with major pharmaceuticals for this thing.
So the aspect of de-risking and then the other end de-escalation is very important, and providing resources that these researchers might not otherwise get. So flipping it over to Randy Burkholder, then Randy, where does the biopharma industry sort of interact here along this pipeline? Again, it's a long story, I know, but if you could give us the high points.
Yeah. I will keep it very short and then give time to some of the other panelists as well if needed, or if you want to press me on any of it, Cliff, feel free. But I would say what Jim laid out is exactly right, and how we look at that is that provides an incredibly important foundation for the biopharmaceutical research companies to look at a set of potential risks they want to take in pursuing preclinical and clinical studies, and trying to make the best bet possible. There's that, it's important to be able to make the best bet possible, but it is always going to be a high risk endeavor, and it's always going to be one where there's a lots of failure along the way, and that's sort of the nature of the beast. But I think the bottom line is, and I stress this because I think sometimes it's lost in the public policy conversation, and there's real risk if it gets lost in the policy debate, which is that we need a robust private sector. Without the private sector, there is no pipeline. But right after that, I would say without a robust public-private partnership and strong public funding, we lose global U.S. leadership as well. And so both of those pieces are critically important. And I'll stop there and keep it high level in terms of the role they both play, except to note that once things do enter the preclinical and clinical phase, it takes a tremendous amount of investment and tremendous amount of risk to try those 12 clinical trials and see if one works in cancer, frankly. And as this data is a few years old, but when we looked from a few years ago, we looked at a basket of medicines and found that 2% of FDA approved medicines could be linked directly back to an NIH grant. That's not to say there aren't a lot of other ways that the NIH and NCI partnership are critically important. But for those medicines anyway, the private sector invested like $44 billion, and the NIH, it was a small fraction of that. Again, I say that not to diminish the absolutely foundationally important role of NCI, but to say that the private sector has to be there as well. And I worry right now that both of those legs of the stool are under a lot of pressure right now, and we need to recognize the value and role of both of them going forward.
Got it.
And I
Thank you
have to
very
say
much.
one other thing, Cliff. I know you're trying to
Sure.
cut me off, but I loved what Dr. Lieu said at the end of his presentation. In fact, I wrote it down, which was, it's the most exciting time that I've ever seen. So thank you, Dr. Lieu, because I wrote that down at the beginning of this, and I said, well, I'm going to say that. No one's really going to believe me, but Dr. Lieu said it already. So thank you. It's an incredibly exciting time. And I say that to say, like, as we think about where we want to forward in public policy, knowing where we've come from and the crossroads that we stand at right now, we need to understand that to know where we need to drive public policy so that we actually keep winning the war and keep delivering actual cures in cancer, while at the same time as preserving, I know you're going to get to this, but preserving our global R&D leadership at the same time. So thank you for teeing that up, Dr. Lieu. I thought your presentation was really, really excellent.
We will get into where that public-private partnership sits right now, and if it is a greater or lesser risk. But Randy, thanks for laying that out for us. So Kate, over to you. So talking about the innovative therapies and treatment modalities and so forth, what about adoption in the community? All this great stuff that Jim Doroshow is funding and Burkholder's people are developing and so forth. What about the output end there? Access. Kate?
Yeah. So, this sort of picks up, right? We go through the process, you the preclinical, clinical, and then you finally get to the point where you got some great new innovative therapy, treatment, prevention strategy that is available. And I think for maybe too long, but for some period of time, we really did think, I like to use the example of the HPV vaccine. There's a vaccine that can prevent cancer, right? Like, wow, that's just incredible. And I think in the scientific community, we thought, well, people are going to be lining up to get this, right? And of course they didn't, and there's lots of reasons why they didn't, and there's different shifts now and all sorts of ways. But really, that impact of having something that you could have in a vaccine that would prevent, and now we have, of course, more that can go down the pipeline into treatment. It didn't. And I think in some ways, this is a really good example of the need for innovation and science and how we actually then get these cool new innovations and effective into practice. And that, again, is in an equitable way. And that's equity within reaching all Americans, no matter where they live, who they are, their backgrounds, but also equity in resources at organizational levels. What does it look like when you have a lot of staffing that you can provide to your patients? What if you are one oncologist that has to cover all of them? All those ways in which that sort of equity can play out. And then we need to make sure that once these things go into practice, of course, that they remain as effective as they were shown in their trials. And there's a lot of reasons, predictable reasons, that when we roll things out, they are not. They are different, right? We are the people that who are receiving these innovative therapies in practice are different than those who are in trials by design, right? We really maximize that internal validity in our design and trials to sort of isolate the effects. But in practice, right, these people come in with all the things that they have that may have excluded them. So it's predictable that there would be differences. The other thing, of course, is where they're getting their care, right? What are the protocols for these treatments? Who is doing the treatments, surgical or otherwise? What are the follow-up? Where do you lose people? This is all things, right, that can actually dramatically impact how effective something remains in practice. And sometimes in sort of surprising directions, right? Sometimes they can be reaching patients and performing in ways that you wouldn't necessarily expect. And then, of course, that in trials, there is one innovation, right? There is one thing you're focused on. And that is both from a sort of understanding, making sure that the patient gets it, but also the competing priorities, right? Oncologists, when they see a patient, there's all, or primary care when they're in prevention. There are so many other things that could potentially be delivered for a patient in a particular time. Even after they are being, diagnosed with cancer, there's still other things and other priorities and preferences and values for the patient that might conflict or compete with delivering that innovation in a way that is effective. And so the broader field of implementation science, but also healthcare delivery research, really is sort of, NCI has been a leader in both training and funding this research. And I and many others are results of our careers and the impact we have had because of this focus on, we need to develop these, but we also need to figure out how to get them in. And then one other just sort of that we also, as implementation scientists, we do these large studies that we're understanding, what the implementation is. But we're also collecting data on evidence of what the sort of impact. And so I think there's a really important role for the whole continuum, private, public, to continue to talk with each other and to each other as we're learning, because some of the data we collect in our implementation study can then, of course, feed back into what is the evidence. Lung cancer screening is a good example, observational and modeling evidence changing the guidelines. So it doesn't ever stop. It's always sort of a continuing, I think, across when we need new innovations, and then, of course, how we get them into practice and back again.
So, Kate, what would you say about the state of the art or the state of the science of implementation science? A lot of people don't know quite what it is, but are we getting better at understanding taking something from trials into the community? Are we smarter about that? Is the science helping us?
Yes. And
okay.
So yes, I do think we are. The field is a pretty new field as far as fields go, but the field is really built on, I'm very much the common norm that I wasn't trained in implementation science. There's only a couple of departments actually that train implementation scientists. So we all come to this field with and many are practice physician scientists, right? We all come to the field with different training and perspective. And I really think that heterogeneity of thought has helped the field. It also has, made it a little complicated. Anyone who is new to implementation science wonders why there's so many darn terms for the same thing. It feels like that. It's very much a field that maybe could be more. We're working on being more clear in our dissemination of our own science, but we're focused on generalizable things that work. That doesn't mean they don't have to be adapted. That doesn't mean there's not tailoring. But we really, in addition to sort of quality improvement, which is really important as well, we want to know, it works here, but does it also transfer and generalize here? And that's where the field is going. So yes, and we have more work to do.
Got it. So we're going from internal validity to external validity,
Correct.
I guess.
And all the messiness. Yeah, and all the messiness that comes in.
Well, thanks. Thank you, Kate. So Cassidy, as it turns out, a lot of stuff doesn't get done or done as well without kind of the input and sometimes guidance of patient advocacy. Can you address a little bit about its role vis-a-vis the innovation pipeline?
Of course. So there's, as you mentioned, Cliff, there's a number of different ways that patient advocacy impacts everything that Jim laid out in his walking through the process. So I want to touch on three things. So one is that patient advocacy groups and patient advocates bring together individuals within their patient community to be able to communicate succinct messages to Congress on the important issues for their constituency. So a lot of patient advocacy organizations keep up with what's happening on the Hill, what's coming down from the president's recommendations, and then what's going on in those congressional conversations, and really distilling that down for our constituents so that they understand kind of what is happening, and then putting together messaging for our constituents to go out and reach out to their congressmen and women and let them know what's important to them. One specific thing that happened recently was the urging of Congress to not cut cancer research funding. So that was something that we worked with our grassroots advocacy network, which is individuals throughout the country, as well as clinicians, researchers, really anyone impacted by research funding cuts to cancer research, which is, I will say, everyone in this country, and really urging Congress not to make those cuts, to actually do increases for the funding for the NCI and the NIH. So that's one way that advocates can really push forward what is important to their communities and making sure that Congress is hearing them. Another piece that PanCan has been instrumental in, and other advocacy organizations also take this as approach, is actually working with members of Congress to introduce bills and acts that actually help the cancer patient population. So When I first joined the organization, we were working on what is now known as the Recalcitrant Cancer Research Act, which actually directed the NCI to develop scientific frameworks for those cancers with a relative 5-year survival rate of less than 50%. And that was passed in 2012, signed into law in 2013. And later in the year in 2013, one of those initiatives that came out of that direction was actually the creation of the RAS initiative, which has brought together a lot of public funding to actually be able to fund RAS research, which I'm threading the needle to Dr. Lieu's presentation, which we now have a RAS inhibitor that had very positive data presented at ASCO and very likely.
You had something to do with the RAS then, didn't you?
Yes, advocates
Didn't know
absolutely had
that.
something to do with RAS.
Whoa.
So
Wow.
it's amazing to see what advocacy can drive forward with pushing the importance of what is important to the patient community. So that is like a very significant and very exciting thing that is coming full circle now, over a decade later. So that's one piece. And obviously the private sector, to Randy's point, also plays a key in that. But I think it's bringing all of those groups together and pushing what is important for our advocacy community. So that's one piece.
Yeah.
Another piece that I wanted to touch on is that patient research advocates are actually involved as part of the peer review process for NCI grants. So patient research advocates serve as reviewers for the NCI grants, provide that patient perspective of, again, what is important to the patient community. Is this research going to impact the patient community? So that's another place that patient advocates and patient advocacy organizations play a role, is connecting patient research advocates to the NCI for those reviews. One more piece that I should have also mentioned is that patient advocacy groups, starting with breast cancer patient advocates, actually pushed for specific funding in the DoD, the Department of Defense, for cancer research funding. And over the years, that has grown. Some years it has decreased. But we recently, in the pancreatic cancer field, PanCan worked with our grassroots advocacy community to push for a pancreatic cancer dedicated line in the DoD cancer research funding, and we now do have dedicated DoD funding for pancreatic cancer research. So again, another way that our community can push what's important and direct that funding.
So kind of the lesson here is that, as opposed to the old days when this is sort of a caricature, but someone would roll in a sick patient or a sick child and kind of look for, I don't know, sympathy or something. That was the kind of caricature in the old days. Now there's so many portals of entry where patient advocacy can plug in including the hyper scientific stuff. I mean, the RAS thing I didn't know about, but that was big deal science. And then it sounds like you need a really acute sense of how Congress works and with the touch points and the timing of whom to contact when. So there's a lot of kind of built up expertise in an outfit such as PanCan, and we're seeing that more and more in the patient advocacy community. So just briefly, Chris, back to you. You talked about the great kind of development here in pancreatic cancer treatment and so forth. Is there kind of a brief story or an example of how that worked its way through the system? Is there something demonstrable about that?
Yeah, I love the fact that this panel is constructed the way it is, because I think that you're seeing, right, this interplay between patient advocacy, PhRMA at the NCI and NIH. And if you think about like the story of daraxonrasib, and would love to hear Cassidy's perspective on this drug as well. It's wild to see the standing ovation at the ASCO annual meeting, like literally in the middle of the presentation. It's kind of gives you that goosebump feeling, right? To kind of see this type of advance in a disease that's historically just been so devastating. And, if you think about, right, all the research. So, again, in school, I'm taught, KRAS is undruggable. These are the reasons why. And you think about the foundational research, right, that daraxonrasib had to build on. And then even when you think about the development of daraxonrasib, that's a drug that, the drug development took over a decade, right, to get to where we are, like literally today. And so, we think about the foundational research being funded, by the NIH, NCI. Yeah, patient advocates. PanCan is just a great example of just a tremendous patient advocacy organization. And then you see the impact of PhRMA, right? And so Revolution Medicines takes this and spends years, optimizing the drug. And now you're phase 1, phase 2, and phase 3. And I know we're going to talk about this, but we talk about safety with phase 1 and efficacy in phase 2, and then like that randomized clinical trial data that you need for regulatory approval in phase 3. And so the time that it takes for that. So you're looking at a drug development timeline that takes like 10 plus years. And certainly that's the story with daraxonrasib. So it really kind of tells you two stories. One is this interplay between everybody represented on this panel working together to effectively get a drug to patients, and then to Kate's point of like the implementation of daraxonrasib, which we could spend an hour talking about, because it's an exciting drug and patients should want access to it, and it's a pill, which means it doesn't require a complicated hospital stay. There's there are intricacies around that, but it does also speak a little bit to the speed, right? And I know we're going to talk, and we need to talk about this right now, because can the United States be fast? And I'll say daraxonrasib, for the most part, was about as fast as you could go, but we need to be faster. And I say this all the time, and Cassie will back me up on this. I mean, tell a patient that it's going to take 12 years to get a drug to market, and they're going to look at you, right, with these wide eyes and say, what? Right? So our patients don't have 12 years to wait. And so is there a way for the United States to become more competitive, more efficient, faster? And we say this not just because we think that we have been and we can be the leader in cancer drug development, but mainly the biggest point here is that our patients have to have access to these drugs, and if we lead, we can provide access to these drugs, and then that can obviously include a global impact as well.
Thanks, Chris. And you are presaging a question that's going to come up about American leadership. Very helpful. Clinical trials. Let's kind of move into clinical trials. In the interest of time, let me kind of tee up at least one thing for each of you, if you don't mind. Doroshow on the NCI strategic plan for clinical trials. Moravec on patient role in clinical trial design and endpoints and so forth. Lieu, shifting of cancer trials offshore. It's one of a bunch of things you can address. Rendell, decentralizing clinical trials to improve patient access and efficiency. Burkholder, the industry role in funding and managing clinical trials, increasing trial costs and complexity. So I've given you each kind of a little kernel upon which to kind of say a few comments. Jim Doroshow, what is the NCI strategic plan for clinical trials? What at a high level is that all about?
We've been working now about 4 years. It's a plan for 2030. I think we've made a lot of progress. Number one, the number one issue was basically flexibility and speed and efficiency, and how do we do that with our clinical trials networks. And so just give you an idea of the things that have been changed. And I have to say, if there's maybe only one good thing that came out of COVID, it's that all the changes that we had to make to keep our clinical trial system going during COVID basically pushed us to institutionalize decentralization of trials, decreasing data acquisition, sending drugs to patients' private physicians, an enormous number of changes that we might not have undertaken had the pandemic not occurred. And those are now, it was a huge lesson. And we basically use that as a springboard so that as of a year and a half, so just for the sake of argument, just so you know, about a third of the trials that we run do not require an FDA IND, okay? And that means that in those trials, there's a lot of trials, a lot of patients. The NCI itself can make major changes without having to get other government approval, okay? And so we have a large extramural panel that helped us, but as of January 1st of 2025, so a year and a half ago, we tremendously decreased the amount of data that we require for our trials. I'm sure it makes sense to you. Once you start doing trials a certain way, and remember, the NCI started its clinical trials networks in 1955, right? And I like to analogize that system to a lot like the Great Barrier Reef, where one layer after another layer of insufficient, it just gets built on, and the worst thing that ever happened to the clinical trial system was Microsoft Word, where you could just cut and paste the same template and not change anything, not think about anything, and just get bigger and bigger and bigger. And so what we've done is that we've cut out. So for example, this is a tremendous, just one example, because there are many, a tremendous pet peeve of investigators around the United States. Why are we collecting adverse events for patients that were low grade, that didn't change treatment, didn't change the way the drug was administered, didn't change the schedule? So we no longer, unless there's a specific research question, we don't require that non-major adverse events get collected. We don't require that standard elements of a physician's history and physical examination, which have no impact on the trial question, get written down and put into an electronic data management system.
Great example. Great example.
I can just tell you, we don't require that imaging that adds nothing to the practice to a specific research question. Those data aren't collected. And when you do all of those things, number one, it speeds up the trials because a larger number of institutions are willing to take on the study because it's not as burdensome. Number two, the cost goes down. Number three, it's much easier to reach a larger population so that accrual goes up. And so the prototype is a study called Pragmatica Lung that we actually put together with the FDA in 3 months. Okay.
That's lightning speed.
Lightning speed. And the major holdup was actually getting final approval from Merck and AbbVie to give us the drug. But the FDA and the NCI agreed in 3 months on the design of this particular study. It collected almost no laboratory data, only whether or not patients died on trial. The outcome was whether patients survived longer, which is the key thing. And imaging data wasn't collected. Biomarkers actually weren't collected. And the study was done. 800 patients were accrued in basically a year in a randomized trial, which had FDA approval for an outcome.
So this is those are great examples that really describe this strategic plan. And you're hitting on reducing burden, reducing cost, increasing accrual across the board. And thanks for those great examples, Dr. Doroshow. So Cassidy, patient role in clinical trial design, can you hit on a few high points?
Sure, of course. So they actually mirror what Dr. Doroshow shared, is really the patient advocates bring really that same perspective. So but from a different lens, if you will. So patient advocates along the way have been providing, and even in more recent years, input on trial design. So what would make the trial feasible and meaningful to patients? What would get patients to enroll in trials, and what would keep them from enrolling in trials? So one of that is trial design, and not copying and pasting from the trial that you did last year. So are those assessments actually needed to answer the scientific and clinical questions? Is the eligibility criteria actually aligned for the population? And are we just copying and pasting because it's what worked for the last one? Or are we thinking through what is actually impactful for this population, and what will allow us to enroll a representative population for this cancer community while still answering the scientific question? So there's a balance of obviously the science and then the patient perspective to make sure that we are answering the question, but we're being as inclusive as possible so that we actually do get patients who want to enroll in the study. Another piece is, can we use decentralized elements to allow patients to receive care closer to home, preventing them to have to travel far distances to participate in clinical trials? So those are some key aspects of clinical trial design that patient advocates do provide input on, really from the patient accessibility and feasibility perspectives. When it comes to endpoints, obviously overall survival is the gold standard for endpoints in clinical trials, but another piece that is critically important to patients is tolerability. So talking through how to assess patient tolerability through clinical trial endpoints, such as including patient-reported outcomes. And we saw that in the daraxonrasib study results, where patients actually did have improved quality of life. There was another positive clinical trial that led to an FDA approval for tumor treating fields for pancreatic cancer. So it's been a very exciting time. And again, that study also used patient-reported outcomes as one of the secondary endpoints, and showed that patients actually had longer time to pain progression when they were receiving the tumor treating fields versus chemotherapy alone. So all of those pieces that are critically important to patients are not just surviving longer, but surviving better with a better quality of life. So those are really two key pieces when it comes to trial design and thinking through. And then the other critical role for patient advocacy groups is educating patients on clinical trials. So helping to debunk the myths. There's still a lot of myths and fears around clinical trials. So helping to talk through those with patients, helping them understand the use of placebos in trials and why those are used, what randomization is, why they need to go to the trial site every week if that is the case, and really helping patients find clinical trials as well, and overcoming some of those barriers that we know. The sites are overwhelmed sometimes with the number of patients calling in. And so patient advocacy groups can also step in and help patients connect to the right person at the trial site when there is a trial that patients are eligible for. So those are all kind of pieces that in the trial design and recruitment. And then also patient advocacy groups are starting to sponsor innovative trial designs. So PanCan sponsors a platform clinical trial called Precision Promise, which we set up the master protocol, if you will, and then investigational arms from different pharma companies could come in and be tested against a shared control. And there are other examples of this throughout the patient advocacy space in myeloma, in leukemia, lymphoma. I believe there's one, actually two in breast cancer. So there's a lot out there where patient advocacy groups are actually stepping in to help design these trials and, similar to the NCI, answer questions that maybe are not as driven by pharma, but are important to our patient communities.
Across the board, once again, those multiple portals of engagement, those PROs loom much larger now. I mean, go back decades, it wasn't about patient-reported outcomes, about outcomes that matter to clinician researchers typically. That's a huge development. So, Chris, you could hit on a bunch of subjects. I know one of your pet peeves is the kind of cancer trials offshore issue, but that and/or a couple other instances about what's changing about cancer trials.
Yeah, I mean, I think you kind of, everybody here understands just the importance of clinical trials. You know, for me, whenever I'm in clinic and I'm seeing patients, you know, clinical trials represent hope. You know, can you imagine if you are a young patient with metastatic colorectal cancer and you go through 2 lines of therapy and those therapies stopped working, you know, and somebody offers you, you know, a clinical trial, it just represents 2 things, right? It represents the opportunity to continue to treat your cancer in a situation where you feel healthy enough to take that treatment. And then the second thing is that you get access to something that somebody has deemed extraordinarily exciting, right? Whether it's a company, investigator, NCI, all 3. And so the importance of these clinical trials in oncology is a little bit different, I would say, than maybe other diseases. If you run a clinical trial in hypertension, maybe you get a drug, maybe you don't. But here, I think it's really considered to be standard of care for our patients. That clinical trials should be considered as standard of care to provide hope, to provide opportunity. And so that's why it's disheartening to me if I see patients and I cannot offer them a clinical trial because they don't exist in our country. And I think we all live through, like even in my career, I've been able to live through a situation where I could find a phase 1 clinical trial of an exciting drug that can make a significant difference in my patient's life. And now I'm in a situation where I see a lot of those trials not being run in the United States. And there's actually a reason for this, and I'm sure Randy's going to talk to us about this as well. But if you're running a company, I mean, would you choose something that's slower and more expensive, or would you go with something that's a little bit cheaper and faster? And you know that time is money in this field. And so, you know, what is really, really important to me is to use this as an opportunity, actually, to say, okay, well, you know, we do need to be more competitive. We need to be better. Well, how do we do that, right? Are there strategies that we can employ to become more efficient? Can we work closer? Even, you know, we've talked about public and private partnerships. Is there a way for universities and the NCI and pharma to work together? Because what you're going to end up with is just a better drug and a better clinical trial. Is there a way to utilize early endpoints? This is an opportunity for the United States to lead. Is there an investment? I mean, because if you imagine that trying to wait for an overall survival endpoint in some diseases may take many, many years. Like, and nobody's going to develop a drug for 20 years if overall survival, say, is like 10 years. And so can the United States and universities and pharma invest in this idea of utilizing an early endpoint like we did in multiple myeloma? Multiple myeloma, minimal residual disease, can be used as an endpoint for accelerated approval to get these drugs to patients faster. There's an opportunity there to run clinical trials in a smarter way. There's an opportunity to utilize real world data to, you know, learn more about, number one, you know, with the clinical trials that have read out, how are our patients actually doing in the real world, right? We know what it's like.
Yeah.
Kate has brought this up about knowing what happens in a very, very insular environment in the clinical trial. Well, what about the real world? And then can we use that to design clinical trials? We're going to have that capability. We have that capability now, but that's only going to grow. And so I think, again, my concern with the United States and clinical trials is that we are going to be increasingly left out of early stage drug development. This is an opportunity for us to change what we're doing to become more innovative, and we're going to have to get faster.
Thank you, Chris. You're making a pretty strong case there. I saw Burkholder nodding his head a few times through that. So, Kate, decentralizing clinical trials, what else is happening that you see as innovative in clinical trial design or constructs?
Yeah, and I think the others have touched on, right, that this is a sort of like innovative, right, that really came out of the pandemic in a way, right? This challenge, we rose as a collective community, patients, advocates, private, public, right, rose to the challenge and said, we need to still do this. How can we do this? And so we have continued some of that and some of this, right, from the NCI, FDA guidance on decentralized approach. The problem is also example, people aren't necessarily taking it up, right? So it's an implementation challenge. There are very good reasons, and some of them just misguided reasons, why institutions aren't doing them. Protocols will be open that offer decentralized, and the investigators at their institutions hit walls with their IRBs, with the standard practice that's happening. And so this idea, right, this top down, which is huge leadership, we can do this now. We still need to figure out how we can do it at the local level and then in community practice as well, right? How do we overcome some of these historic entrenched inertia behaviors, address the barriers that so people, we go from that, 7%? I completely agree, standard of practice. Right now, I think in the US, about 7% of cancer patients are on clinical trials. How do we get closer to that 100% mark? Probably not at 100, so that we actually can speed up and improve care in more rapid ways.
Thank you, Kate. And speaking of under-enrollment in clinical trials, and we can get into this at another NCCN event, is disproportionate under-enrollment for certain socioeconomic groups, which is it's a big fault of the system. Let's just say it there. Randy Burkholder. Randy, so from the industry standpoint, the clinical trial landscape it's evolving, but it's kind of shaky as well for some of the reasons that Chris and others have mentioned. Where do you see us now from the standpoint of industry and clinical trials?
Yeah, thanks. And I was nodding and I was feeling the pain, Chris. So thank you for because it all resonates. And I want to just pick up on one thing you referenced, which was a reliance on overall survival versus surrogate endpoints. And I would just say, that's the European model of payment right now. Is we might pay for your new cancer medicine if you hit an arbitrary cost effectiveness threshold and you demonstrate improvement based on overall survival. And that's just a recipe for the failure of the R&D ecosystem in the US, frankly. And why it's so painful to me that the administration would be proposing to mimic that exact model through foreign reference pricing proposals. But we can get to that in a future question, Chris. But I just had to say, if we care about preserving this ecosystem, that is something we have to care about. And when Chris got to his questions, and they were exactly the right questions on his last slide, the version of the one I had in my head before he got to the last one was, will we pay for these? And I think we do need to figure out how, but we also need to make it clear we will, because that's part of the equation here too. But in terms of the ecosystem, I like I said, Chris, everything that you were saying, everything the other panelists were saying was completely resonating with me. I think the bottom line there is that we all need to want to preserve our role as a global leader in biopharmaceutical research, but that means we also all need to be committed to preserving our role as the leading location of clinical trials globally. And that's going to take a concerted effort. And I think part of that is making sure that the US as a location is as attractive as possible to everyone involved in that process, including the companies. You're right, Chris. Sometimes it's a tough equation sometimes, but but it's one we need to make sure we are doing all we can to bolster the opportunities for more clinical research in the U.S., which right now, and I know we'll get to this too, but is under pressure like never before, and that's partly why you see what you see in terms of some of the ex-U.S. Clinical trial sponsorship. The only other thing I'd want to say, two other things, maybe quick to level set. One is that there are pressures, but there is at the same time, there's still a robust clinical research activity in the U.S. And I wanted to level set on that as well. And as of a couple years ago, our companies were sponsoring over 5,000 clinical trials here in the U.S. in all 50 states. So there is a strong foundation to build on. We just need to make sure we are shoring it up. And I would also stress just what's already been said, which is that model is one that, again, is based on high risk of failure and potential opportunity to succeed, but it's one where we like the opportunity to fail. That's what our model is all about, and that's why the public-private partnership is so important, because we'll take those risks, and we need partners who are helping us improve the odds as much as we can there. But because only 12% of any medicine that ever enters a clinical trial is going to ultimately get FDA approval, and that number hasn't changed much over the last 10 years, but the number that has changed is, to your point, Chris, it takes too dang long. Is the length of time and the cost of those clinical trials has soared. And I would just cite an IQVIA report from a year or two ago that said complexity is the new normal in clinical research. And so we need FDA to be the gold standard, but we need to figure out ways to make it simpler and quicker at the same time. And we can get into
Fair enough.
I'll stop there.
Well, that's fair enough, Randy. I do want to get to the AI question, but I think we're closer now to, I'm going to combine these two issues. It's the American leadership, because you all have gotten into it already. So I want to combine the American leadership question with the federal action question. American leadership is, what are some of the logistical, financial, political factors that have enabled American leadership, but more importantly, are perhaps undermining American leadership? And with that, are there any federal actions that you think have been not de-risking, but adding risk to the situation with American leadership and the kind of the vitality of the pipeline that was referenced earlier? So I'm not gonna put this on Jim Dorshow's plate just yet, but if he wants to say anything about it, Jim, we'd welcome it. But if we could kind of get started. Actually, Randy, let's have you kick this thing off. And again, I know you could cover a lot, but where stand we now on your outlook for American leadership and any federal actions that you think might have affected it? Randy, give us the short version.
It's 2:55, and we all wish we had another hour here, right? So
give us a short hit on it.
I'm going to keep a really short hit and give other people some time, hopefully. But so ask your question again, Cliff. I just got
so what are the factors that might be affecting American leadership? You've already mentioned a few. And are there any recent federal actions that have, let's say, caught your attention in a way that might be further uncertainty generation?
Yeah, well, I just want to, I want to level set, and I think, Chris, you were alluding to this as well, but on why this question of leadership is so clear and present for us all, I think is because I think sometimes there's an assumption that our leadership in this space is a given, and that's a really dangerous assumption. It's not a given, and it's not a guarantee. And I think looking at the degree to which China has advanced and is frankly nipping at our heels in some of these areas is very illustrative of the fact that our leadership is not a foregone conclusion over the next even 10 years in this space. So I think it's really important that we make sure we take the kind of steps Chris and others were talking about to support a clear and predictable regulatory environment, but we also need to preserve a strong market incentives for those advances as well. So just by one example of why that's such a concern for me is that as of today, the Chinese have in fact overtaken us and now lead in exactly what you were talking about, Chris, cancer clinical trials. They're at 39%. We're now at 32%. And that obviously has flipped. And that's why I said, Chris, I'm nodding and feeling the pain, because we are. And I don't know if some people realize how fast that change has happened. But in 2009, China was at 5% of cancer clinical trials, and now they're at 39%. So this is a strategic priority for them, and it's changing a lot. So only other thing to say, I promised to keep it quick, was I appreciate some of the steps the administration has been exploring and pursuing to answer that question of how can we make it faster and more flexible and more efficient on the regulatory side. But you can't do that on one breath and in the next push for sweeping government price controls. That would effectively cede leadership over the next 10 years to China. We can get to that too, but those have to work together.
Thank you, Randy, on those points. Kate, I know you've got another take on it as well.
Yeah, and I agree with all points. I think the what I feel in my day to day and is the impact that it's having on those that are engaging in across the spectrum research and science to try to advance and improve cancer care delivery. And I think that from American leadership perspective, right, those of us that are in it right now, we are feeling it, and we have experiences, and we sort of can identify ways in which there are some things that even from scientific process that were maybe not as efficient as they could have been, and there is some things that can continue to improve. And this, of course, was leadership that not was just the current administration, but that over the years. But I think that the thing that keeps me up mostly is that long-term vision of the pipeline of the people that are not coming into these fields, and that what it will look like in 10, 20, 30 years. Because
the workforce, you mean the workforce?
The workforce, those early stage investigators now that are trying to make it, but even those small children at home, right, that are hearing. When I grew up in a very rural Northern California, RUCA 10, very much the populations that a lot of the administration is really trying to reach and include in science. And I didn't know anything about any of this, but I heard from American leadership how important science was and how we are leaders in science innovation, and we really value science. And that led me down a pathway, but that was long and winded. And the NCI, when I was done with my PhD, I searched postdocs in cancer prevention, and it came up, and I took a chance, and I applied, and I got in. And so this commitment to heterogeneity of scientific thought, I think, has always been really important. But we look to our leaders and to the NIH, even at a young age, to take that chance and be a scientist across the country. And so that's what I'm worried about most. And I think that those are actually values that the American leadership is trying to convey. But I think maybe they don't know that there are many people, I am not alone, in that sort of trajectory. And so we are here, and I'm worried that we maybe won't be in the future.
Thank you, Kate. And I have to mark that you got into some interesting territory politically with regard to your earlier discussion of equity. That word didn't used to have such connotation as it does now, and heterogeneity, which translates into diversity, another interesting word of late. Cassidy, do you have any views on this particular aspect of American leadership or federal actions affecting that?
So I think just echoing everything that everyone said, I think that's critically important. I think from the patient advocacy perspective, really where patient advocacy groups can play a role and are playing a role, and Kate, to your point of the federal funding and uncertainty and building up the pipeline of researchers that are interested in cancer research, a place that patient advocacy groups can play a role is actually also to help fund cancer research. So PanCan and other patient advocacy organizations actually do peer-reviewed funding for research grants to bring people usually focused on those young investigators into the cancer research pipeline so that we can build a community of cancer researchers that we have found often go on to get federal funding. We've actually seen an ROI in our investment in our early career investigators. For every $1 that PanCan funds them, they actually go on to receive an additional $11 of funding through other resources, including federal research. So I would say patient advocacy in this time of uncertainty of what's happening with American leadership is continuing to build the community and help to fill those gaps where they exist so that we don't completely lose that pipeline. And obviously private dollars from nonprofit organizations are not going to compete with NCI level funding, but they do help bridge that gap and build that community.
Got it. So I want to just ask each of you briefly to name one thing about AI in the cancer innovation pipeline. And we don't have time to go into a lot of detail, but give me one kernel of insight vis-a-vis the role of AI in cancer innovation. Jim Doroshow, can you mention one thing that excites you about AI in cancer innovation? You might want to hit that mute button again. It's okay.
I'll just bridge the last question and this question, right? Because
Sure.
my biggest concern is that we basically are far along in the process of pricing ourselves out of the business of doing cancer clinical trials. We just can't afford to keep doing what we're doing at the slope of the cost increase that is predictable and very difficult to try to bridge. And so my hope is that we will utilize the remarkable changes in what's available in terms of the AI tools that we have now, and that we will have in a matter of months to write protocols digitally, to collect protocols automatically, data from EHRs, to basically utilize AI tools to develop our EHR builds for the protocol documents and the orders for physicians to use for patients who enrolled in trials. These are just enormously expensive, and the hope, in my mind, this is the hope, is that these new tools will allow us to do this much faster and much cheaper to try to bend the curve, the cost curve, which I think is really going to is imperiling our abilities to do what we want to do.
Well, thank you, Jim. Once again, you're hitting on efficiency in a big way, and AI may be a way to make the system more efficient. But if the guy at NCI is saying these things are costing too much, I think we better listen up to him. So, Chris Lieu, what do you like about AI and cancer care innovation?
I think that we're seeing a proliferation of companies that are interested in using AI to identify patients for clinical trials by searching through electronic health records. I will tell you that we live in an extraordinarily fragmented electronic health record system, which makes this an extraordinarily difficult problem to develop an AI system that can interact with multiple different systems, which in and of itself is an issue. There's also a bit of a security and data risk whenever you ask. And I think every institution, certainly understands this and is likely very conservative about this, about having any program go in and start searching through patient data is an extraordinarily risky proposition. So it's something that needs to be handled with care. But you can imagine as trials continue to become biomarker directed, which might mean that you're looking for 1 or 2% of the patient population, that a system that's able to read through and screen a large number of patients may be able to help you identify patients for clinical trials, and may also be helpful for things like preventative trials. And then to Dr. Doroshow's point about even collecting this data, when you think about our clinical trial offices and having people just enter in things like vitals and labs and stuff that should easily be abstractable by AI and dumped into an electronic data system, that is a situation where AI may be able to cut costs, become incredibly more efficient, in some ways, honestly, more accurate. And, I always worry about AI and what that does even to our workforce, but this is a situation where none of our clinical trial offices are ever fully staffed. And it can actually solve a problem that we're actually having even at the university and clinical trials level of being able to even have enough staff to do this. And so it would enable a solution that may make us more efficient, more accurate, and even cheaper, and even deal with some staffing shortages that we have.
Points very well taken, Chris. Thank you. Kate, AI?
Yeah, I think similar for me, the really exciting potential of a lot of the AI in cancer care is to reduce the burden on clinician staff, patients, and that in ways that, sort of really are quite diverse across the spectrum, from sort of increasing the efficiency of auto contouring of radiation to progress notes to physicians. Of course, the downside to a lot of these, right, is really to make sure not only are they accurate, but they don't turn into just something that adds on to the work, right? And that is a big risk. And I think we've seen a lot of examples and we're early on, but really to make sure that we're not just, piling on more and more stuff that could be reducing, but actually is adding. So a lot of potential and danger.
We don't want to pile on more stuff while Jim Doroshow is trying to depile all that stuff.
Correct. And our workforce across the board are already
exactly.
Way too thin.
Thank you. Exactly. Cassidy, the AI angle?
Yeah, so I think for patients, we know that our patients are using AI to just ask questions about their cancer, to ask about clinical trials. And I think it's here to stay. It's powerful, and it does have the ability to lessen the workload for patients and clinicians. But to the point of AI can make mistakes, it's only as good as the input that the patients are putting when they're generating their questions, and it's only as good as the data it's pulling from. And we know that the available public data on clinical trials is not always accurate, timely, or all there or correct. So I think there is that piece that there is a potential of downside of presenting to patients a clinical trial that looks like it matches their situation based on the question they asked, but then when they talk to their doctor, it's either not enrolling or they don't actually qualify because there's a biomarker that's not listed publicly that they actually have to have. So I think there is great potential in AI. I think it could help decrease the barriers to access to clinical trials, but I think there also are some pitfalls to watch out for, because we all know it only is as good as the data and the inputs that it receives as to what it gives out.
Great. Thank you, Cassidy. I'm going to set you up, by the way, in a minute. I'm going to ask you we got 2 questions on increasing access to clinical trials in rural areas and where we need to go with that. So I'm tipping you off to that one. Randy, anything you want to add about your folks' take on AI?
Not really, in the interest of time, except to say I agree with everything that's been said on the research and development and clinical trial side. That's probably the leading edge importance. Only other thing I would add is AI is going to impact healthcare across the board. So we really need to make sure that AI works for patients and caregivers and consumers in the US so that it can help healthcare work for patients and consumers and caregivers in the US. That's easy to say, hard to do, but I think that needs to be a poll star for us.
No, it is a North Star concept. Thank you very much for that, Randy. Cassidy, on the rural access to clinical trials, and if there's any other panelists that has a bit to add to that, please do. We got at least 2 questions on that. Cassidy?
Sure. So when it comes to rural access for clinical trials, I think it comes back to a lot of the things that we've discussed. So one is those decentralized trial elements. How can we bring clinical trials closer to where patients are being treated, including in the rural communities? And how can we support those clinicians and healthcare practices in the community to be able to run the clinical trials? Because it's not just bringing the trials there, but it's making sure that they have the staff to support, that they have the systems to support. So it's really a systemic issue of making sure that they have the resources needed to run clinical trials, because from the academic perspective, we all know that there are a lot of resources, and even the academic institutions, as Dr. Lieu mentioned, are short-staffed when it comes to their clinical trial offices. So I think a big piece is not only the decentralized piece, but then to Kate's point, how do you execute and how do you implement those things? I think a great example of how this has worked through the NCI is actually the minority MCorp sites that are involved in the NCI-sponsored clinical trials. So that really works with institutions that can access more minority and diverse and inclusive populations to be able to work in to access clinical trials. And sometimes that's a hub and spoke model where there's a main cancer site, but then there are satellite cancer sites that are in the patient communities where they actually can access those clinical trials closer to home. So I think it's a multi-pronged approach of not only raising the awareness for the patients in those communities that those exist, but then putting in the systems to actually make those clinical trials available at those sites.
And we got a question that's zeroed in on advanced practice registered nurses. So that more broadly, can we better utilize the workforce and the skills of different sorts of healthcare professionals to enable clinical trials, including in rural areas?
I will say absolutely. I will let my other panelists chime in as well. But I did have the chance in some of the conversations that we've had with other organizations, including ACCC, and had a chance to interact with some individuals that were in nurse practitioners and advanced practice providers that actually are serving as investigators on clinical trials and helping to reduce that burden. That it's not only an MD that is an investigator in a clinical trial, so it really helping to train up different specialties that have the knowledge and the clinical aspect to actually be able to run and support those clinical trials. So I think they are critical in helping to build up the workforce to really bring access to clinical trials.
Thanks, Cassidy. Kate, on that?
Yeah, I was just gonna two echoes, right? The NCORE sites really, and there's an open call. Anyone want to apply on the phone? There's an open call for new NCORE sites. They're really transformative, and they did start more in the therapeutic, but they have cancer care delivery trials, and they really are an opportunity to build out an infrastructure. But I think anytime, right, this is where maybe the science of implementation can come in, right? Who is the right person and why? And so we get stuck in these ways that we think this might be the right role, but APPs, for example, well, what other relationships can, maybe there aren't specialists at a community practice, but what are the ways in which you can build incentivized relationships to break down some of those barriers? Again, where I grew up, the closest cancer center is 4.5 hours away. And so what does that mean? And there's state line issues, right? So we could go over to Reno, but we can't go necessarily to Reno for telehealth or other things. So there's a lot of things that come into bear that why these things aren't getting implemented. But I think to sort of step back and say what could work and why hasn't it worked, and then get the support, will reach more patients.
Sounds good. I'm going to consolidate the several questions we got about payment. And a few of them deal with affordability to patients. There's costs, it's like there's out-of-pocket costs for patients or even getting to a trial site cost. So patient-related costs and affordability. Part A, Part B, payer support for clinical trials. Whether it's Medicare, Medicaid, commercial insurers, what have you, can we get them, I'm paraphrasing here, more on board with their support and enablement of clinical trials? Who wants to take a shot at either of those payment-related issues? All right, well, I'll go to Chris Lieu first then. Chris, getting paid here, how does that figure in, whether it's patient affordability to access and or payer support for clinical trials?
Yeah, I mean, I'm happy to touch briefly on both. When it comes to, right, some of the drugs, I showed that chart regarding the cost of 5-fluorouracil chemotherapy at $6 and, some of the immunotherapies that cost in excess of $10,000 per dose. I mean, that is, it is wild. And certainly, right, there's a lot of things that kind of go into that. What does Medicare pay? What does Medicaid pay? And then even what does insurance pay? I think from the most practical standpoint, the biggest issue I have is with our underinsured or uninsured patients. And so, what do we do in those situations? There are times where our health systems step in and subsidize that care. But when we talk about some of the CAR T therapies, I mean, that's in excess of $300,000-$400,000, and there's not a single hospital system that can eat that kind of that type of cost. And I got to hand it over to some of our pharma sponsors who step in and give drug for free, right? And so it's kind of like what you're seeing is like a cobbling together of a safety net for some of our patients, and that's unfortunately just the system that we live in. But I stress out about my underinsured or uninsured patients, and then we have Cassie from PanCan here who has supported tons. PanCan has supported tons of our patients, and so unfortunately this has become a little bit of a hodgepodge group of safety nets providers essentially that have really kind of stepped up. But I think that's at least part of the solution, even though it's not the most ideal one that we have. And then in terms of clinical trial support, for insurance providers, I think that almost all the standard of care tests and procedures usually do get billed to insurance providers, where the sponsors take on any additional cost that wouldn't necessarily be standard of care. But here, right, I mean, continued legislative and policy support to say that, this is part of standard of care for oncology. And so even, and again, I've seen this, where insurance providers are taking the cost of at least the standard of care parts of clinical trials. I mean, that's going to continue to be increasingly important because, again, this is such a critical part of patients' care in our country.
Thank you. We're getting call outs on this issue as well, but Kate, anything you want to say? And I'm going to go to Cassidy after that with regard to financing of trials and/or related patient affordability.
Yeah, to just maybe build on that. For and underinsured patients, when they then have a diagnosed cancer, they have a lot of They face a lot with that they can get care. But they also face a lot on that sort of process to get there, right? So a lot of times that process between screening and getting a positive diagnosis, that then you may be eligible for emergency Medicaid or not, or might be charitable funds. They can't get that diagnostic workup. And so we end up having patients that could have maybe had a more early stage cancer that could have been maybe totally taken out, right? And they maybe didn't need all of that. And so I think as much as we can as a system, and it's hard to do this because we're siloed and we have, the system that we have, really look across the perspective that if we were to maybe invest funds across, right, to support, we actually could reduce those costs downstream as well. But it's really, really quite complex, but you feel it anytime you try to interact and, turning away patients that could have treatment. Sure. Yeah.
Thank you, Kate. Cassidy on that. And then Randy, I'm going to ask you about kind of industry's role to kind of respond to some of these really expensive therapies and how you can maybe help patients access them, especially in clinical trials setting or other. Cassidy?
Absolutely. So I think when it comes to cost, obviously one thing is how patients are impacted in cost. So for the underinsured or uninsured patients, getting access to trials is sometimes even more difficult for patients that are insured. And so there are, since this is a policy summit, so some things that are in the works is there are advocacy groups such as the American Cancer Society Cancer Action Network that has just worked with senators to introduce the Clinical Trial Modernization Act that's been introduced a couple of times. It's just been reintroduced in the current congressional year. But really that aims at accessing allowing larger groups of patients to access clinical trials by removing some of the barriers to access, including allowing sponsors to help pay for some of the medical or non-medical costs for participating in clinical trials. So this could help overcome some of those economic barriers to clinical trial access for the underinsured and uninsured patients, as well as even those who are insured that have high copays and those types of things. So there's lots in that act, but there's concerted efforts across the patient advocacy community to make sure that those underinsured and uninsured patients aren't hit with the cost of participating in a clinical trial that could potentially improve their outcomes.
Fair enough. Thank you, Cassidy. Randy, your companies, they charge a lot for these cancer therapies, but can you talk about perhaps the role in clinical trials and kind of what companies can do to ease the affordability issue?
Sure. Well, I think in particular, in terms of clinical trials, I think I could probably speak more to the underinsured and uninsured issue, frankly. Sure. But in clinical trials, I think our companies do all they can to make sure that is as seamless and painless as possible for patients from the financial side. We don't want that to be a barrier to patients in clinical trials. We don't want it to be a barrier to any patient with cancer facing treatment, frankly. And I wish I didn't have to say it, but I got to say it, that we're still here talking about the problem of the underinsured and uninsured. And in 2020, the 340B program was $6.6 billion in sales. And today I hate to ask anyone to hazard a guess, but it's $81 billion today. And we're still talking about the need for help for the underinsured and uninsured. Something's broken there. It's got to give. And I think that can be part of the solution to the broader term issue of patient affordability.
Yeah.
I think, and maybe we'll get to this in a future question. I don't know. But I think beyond that, really making the Medicare Part D prescription payment program work for cancer patients is another short-term step we can take to ensure that cancer patients have affordability.
Medicare Part D for cancer, absolutely. So I want to ask our panelists this, and gosh, I'm thinking all the subjects we talked about could be the subject of an all-day NCCN Policy Summit. But here's the question I want to pose to you, and you got to answer it in under a minute, not 61 seconds. Here is the question. And Jim Doroshow, we're going to start out with you, and you want to just get ready to answer this one, set a good example. If you could push one button or pull one lever, Jim, with regard to the policy layout, the policy landscape, one button, one lever in policy that you are highly confident would not only protect, but enhance the cancer care innovation pipeline, what would that be? 60 seconds or less. Jim?
Okay, I'll do it less than 60 seconds. I would make it mandatory that if a new anti-cancer agent is approved by the FDA, then a consistent and large supply of drug be made available to the NCI to rapidly activate combination trials or trials in rare cancers without the kind of headwinds that we have to go through to get approval for those studies.
Jim, that is a concise and powerful answer. Thank you very much for that. Cassidy, can we go to you next? What's the button you'd push to the lever you'd pull?
Sure. I think for me, it would very much be access to clinical trials for patients and ensuring enrollment and adherence to clinical trials. I mean, we know that clinical trials are what drives the science forward. Obviously, there's a lot of science behind it before you get to trials, but without patients being able to access, participate, and stay on clinical trials to be able to answer those questions in a timely manner, we're not able to push this space forward. So I really think improving access to clinical trials policy that would make that available to patients, regardless of which zip code they're in the United States.
I'll take that too. Kate, what do you have? What's that button you'd push?
Oh man. Okay. I think I might require that there be like a very disparate perspective on a research grant. And what I mean by disparate, just that could mean lots of different things, but that really there is a spectrum when those basic scientists, implementation scientists are thinking together in addition to other patients and advocates, but that really it's a requirement, right? That there's some perspective and that maybe we all have to be trained in communicating our science better to the American public, which I think, yeah, that's what I'd say. There's probably others, but that's all stick with.
Well, if you can't implement it, what good's it going to do? I mean,
Right,
that's
and if
on
we
the
can't
critical.
communicate it to our public, it probably is hard for them to understand what we do.
No kidding. Well, we hope you'll continue to lead the way in implementation science and cancer care. So, Randy, you're a big policy guy. This is your stuff. Pick one.
Oh, man. Like I'm laughing too. There's too much to choose from, right, Kate? But
I know.
all right, 60 seconds. I would fix the pill penalty in the IRA's maximum fair price program, which already is harming research and clinical trials for small molecule medicines in cancer and beyond. I would rescind the proposed most favored nation policies that were put out through CMMI and Medicare and Medicaid. And I would, as I alluded to, I would make the Medicare Part D prescription payment program actually work for patients right now of the beneficiaries who hit the Part D maximum out-of-pocket cap, less than 5% of those patients. Those patients are all likely to benefit from that. The idea of this was you help patients stay on their medicine by avoiding a upfront single month, very high cost and spread it out over the year. Less than 5% of patients who hit the cap are actually enrolled in the program. We could take some simple steps to solve that and would love to see that happen.
Okay, in your 60 seconds, you covered about 4. That's pretty good, Randy. Chris Lieu, what's the policy lever you'd pull?
Yeah, so in clinical development for oncology, you can be slow or expensive, but you can't be both. And I'm not sure we're ever going to be like cheap. So we got to be fast. And so I want to see policies really just investing in speed of clinical trial. This would include a review of, what the FDA requires for early drug development. It means, potentially incentivizing accrual, federal investment in investigating early endpoints. And even, you can federally mandate health systems to have a certain speed, even in clinical trials and accrual goals. And so that's what I'd like to see.
Good gosh. Those are 5 great policy levers to pull. I wish we could pull them all at once. And they're all just directed to the point of this summit, which is to say, not only to recognize how cancer care innovation has occurred and evolved recognize further that at times it can be under stress, and we need to think about de-risking it and kind of taking away some of the uncertainty, but now taking into the future, including from a policy standpoint. And before I hand this back over to Vicki, I just want to say that I don't know about you, but the last 90 minutes have been entirely invigorating to me and interesting, fascinating, and insightful. And if you wanted to know about the changing face of cancer, past, present, and beyond, you could not have done better than get somebody like Randy Burkholder, Jim Doroshow, Chris Lieu, Cassidy Moravec, and Kate Rendell on your panel. You're great. I hope we can do something like this again. And please continue to what you're doing. You're all national leaders in this. Thank you all so very much. Over to you, Vicki.
Thanks so much, Cliff. Good afternoon, everyone. Thank you again for attending our June Policy Summit. Wow, what an incredible program. I know I certainly learned a lot from the remarks from Representative DeGette to Dr. Lieu's really cool history lesson and his keynote presentation, and the really interesting and important discussions by our panelists. My name is Vicki Hood. I'm the Senior Manager of Policy and Advocacy for NCCN. And I just wanted to take a quick moment to once again thank all of our speakers for their participation in today's event. And a big thank you to Dr. Cliff Goodman for his always outstanding moderating skills. I also have to recognize the entire staff at NCCN for all of their behind-the-scenes work to support this summit, especially those on the meetings team, business development, and marketing teams. As part of my role here at NCCN, I have the privilege of managing the Policy Summit series. But really, I'm just very fortunate that I get to work with my colleagues on the policy and advocacy team, who are the reason that these events are a success. So I want to thank my coworkers in my department, but I also want to give a special shout out and recognize the outstanding work of Aaron Bailey, who I'm going to take a quick second to quickly embarrass today. Aaron led the planning and execution of this entire program. And while this requires an incredible amount of work, I also want to point out that the timing of this summit has been especially interesting for Aaron because his wife is expecting their first baby at some point this week. So as you can imagine, the lead up to this event has been anything but boring for Aaron. So Aaron, we are so thankful for all of your work, for everything you do to support those impacted by cancer, and congratulations, we are so excited for you. On behalf of the entire policy and advocacy team, I would also like to sincerely thank all the supporters for today's summit. The generous support of our funders allows us to put on these programs and cover important oncology topics that we are so passionate about. And so thank you again for your contributions that allow us to continue to do this work. I'd like to highlight a few upcoming NCCN events for 2026 before we let you all go. NCCN will be hosting a free patient webinar on non-small cell lung cancer on July 27th, so register now to attend. This September, NCCN will be holding its annual Heme Congress in New York, so registration is now open for virtual and live attendance for that as well. The policy team is so excited to launch our first ever two-day summit this fall. So please join us in Washington, D.C. for our new two-day event focused on policy strategies to shift the paradigm in cancer screening and prevention. Over the course of the 2 days, this dynamic forum will provide an opportunity for speakers and the audience to explore the advancements made in screening and prevention at the population level, but also at the individual level. We will explore advancements made, as well as the opportunities and challenges that still exist. We will have panel discussions, keynotes, best practices presentations, and plenty of time and opportunities for breakout discussions, and we're also hosting a networking reception as well. So we hope to see you there on October 5th and 6th at the National Press Club in DC. It's that time again. We're already so excited for NCCN's annual conference in 2027, which is moving. So for the first time, we are headed out west. Save the date for an event focused on advancing oncology nursing that will take place the day before the conference starts. And then NCCN's annual conference will be March 19th to March 21st. So we hope to see you in San Diego. And again, thank you again to our speakers, our supporters, and our audience for being here today. We appreciate you and look forward to seeing you soon.